reach Sunita ma'am is
Yes, ma'am is here.
Yeah, I took a Wi-Fi. I had made my Wi-Fi off, thinking कि mobile connectivity is better.
No.
So all the election contestants, congratulations and all the best to you all. Rekha, I was asking Dr. Sudha Murthy's sister Deshpande. She's a gynecologist in Bangalore. Are you
Madam,
aware
she's
of
not-
her?
Sunanda
She's
Kulkarni.
Sunanda
Sunanda
Kulkarni,
Kulkarni.
madam. She is Kulkarni. She is not Deshpande. Deshpande is Sudha Murthy madam's brother in USA.
Okay, so that Dr. Kulkarni, are you aware of her? You know her?
Yeah. I know her very well.
Okay, I'll give you a call in the evening.
Okay, madam. Fine.
Dr. Sunita, Dr. Sudhamurthy, Rekha was able to invite her for one of her BSOG conference. She was very lucky to have her there.
My investiture ceremony, Sudha
she
Murthy
was
madam had come. Yeah.
Fantastic. I will
we
take your help, Rekha, to connect. I'll let you know in the evening. Let's start the webinar. It's 4 o'clock.
Madam. Yes, madam.
Dr. Richa and Dr. Santwan are today's coordinator. I request them to begin the proceedings.
Very good evening, everyone. Dear esteemed members and guests, I am honored to welcome you all for the inauguration of this webinar of the Foxy Endoscopy Committee. I am Dr. Santwan Mehta and my colleague Dr. Richa Pal welcome you all for today's webinar. This webinar is organized by the Foxy Endoscopy Committee in association with the Bangalore, Baroda, Dibrugarh, Guwahati, Navi Mumbai, Shimoga, and Surat Obs and Gynec Society.
Hello everyone. This webinar is organized under Foxy and thanks to our office bearer, Dr. Jaideep Kank sir, President, Dr. Madhuri Patel Madam, Secretary, Dr. Janmay Jaya Mohapatra sir, Vice President, and Dr. Subhash Malia sir, Chairperson, Foxy Endoscopy Committee. It gives me great pleasure to introduce the driving force behind today's enlightening gathering, our own Dr. Sejal Nayak Madam, who is the convener of today's program. So hereby I welcome Madam to this virtual platform.
Once again, I thank Foxy Endoscopy Committee and the other Obs and Gynec Society of Bangalore, Baroda, Dibrugarh, Guwahati, Navi Mumbai, Shimoga, and my own Surat Society for joining hand and collaborating for this today's webinar. I welcome Dr. Subhash Malia is here, the chairperson of Foxy Endoscopy Committee.
Thank you very much. Please carry on. Thank you. Thank you very much. Namaste, Sunita madam. Namaste, Sunita madam.
Namaste, Subhash.
Madam. Bharti madam. Namaste.
So before starting this inaugural, we'll just seek blessings from Lord Ganesha and a small Saraswati Vandana.
Recording in progress.
We are not able to see the slide share. Yeah, screen is seen. Please make it full screen.
Probably that is a video.
The slide is not changing, Sejal. It is not coming to the prayer one. It just, it's not in the slide share.
Hello, ma'am. Is it, hello? Hello?
Yeah, it was not playing, it was not showing the full screen.
Was not playing, ma'am?
That's, yeah.
Is it showing,
Yes,
ma'am, now?
yes, Dr. Richa, your screen is shared now. Just go to the full screen and play that thing.
Your
It will be
hand is
visible to
already
all.
on full
Is
screen.
it playing?
Saying it's not moving. Huh.
Yes, Dr.
Yeah.
Richa.
You have to click on the video.
Is it a video or just a slide?
No, no,
video.
it's just a shloka. It's no video
Ah.
is not there.
What we can do, we can sing a slok. That is fine.
Yes.
That would be much more, you know.
Yes, Sejal. I think that's what
Feeling,
perfect.
feeling,
Sunita,
Sejal.
Sunita madam will sing.
Madam Saraswati Vandana. Yeah,
Yes.
Kundini.
Yeah. Yeah, Kundi
Bindu tushar dhawala.
या श्वेत पद्मासना
Barabar. Ya Shwet Vastravita. Ya
Shweta
Ya Veena Varadanda Mandit Kara. Ya Shwet Padmasana. Ya Brahmam Chita Shankara Praviti
संदेव
Devai Sada Purita.
Tamam Patu
सरस्वती भगवती
Nishesha Jadyapaha.
शेष जाग्या वहाँ.
I hope very bad, but
I think Richa, your internet is slow. That's why that video is not playing. Let us move ahead with our introduction with our chief guest.
Okay, so I would like to welcome, first of all, I would like to introduce our chief guest, Dr. Sunita Tanduwarkar, madam. Madam is the head of department of Obs and Gynec department of the Ruby Hall Clinic. She has been consultant of many hospitals. She is the president-elect Foxy for 20-25 years. In her cadence, she has got so many awards and she has so many publications. Madam, over to you to bless this occasion.
Thank you, dear all. Thank you. Good afternoon. Am I audible very well?
Yes, ma'am.
The volume. First of all, thank you for having me in this beautiful webinar, which has societies from all the corners of India, from all the zones. The Endoscopy Committee of Foxy, which has been led by Subhash Malya, is such a rocking committee. I can see in 3 years, Subhash has taken endoscopy to every smaller societies apart from just the big society. That is what the committee chairperson is supposed to do. With his passion and dedication, it is not only showcasing his talent, his knowledge, because he's selected on that post because he deserves that. Obviously, he has proven, and that's why he's on chair there. What we expected from Subhash was going to the smaller city, teaching the endoscopy over there, and that's what he's doing all across. He's recognizing many centers so that those centers can independently cater to those area like-minded endoscopy learning, those young people who wish to learn endoscopy don't have to travel across the country. They can go to the nearby centers. So Subhash, you have done amazing job. And you have chosen Sejal, the right national coordinator who helped you in many places to accompany you or to conduct your program. So what happens, the 3 years work, what you have done, the next committee chairperson takes it, ensures that the efforts of the previous committee chairperson doesn't go waste. Just close the door. But at the same time, if with her creative idea, how Subhash has taken the committee 2 steps on a higher level, the next person conducts all the program, ensures everything is follow on, and takes with her creativity to another level. This is how the organization and individual committee, they grow. So I really congratulate Sejal for thinking of stepping in the chair of endoscopy committee so that you can give not only the justice to the work, hard work, efforts, what Subhash Mallya has put in, but also to take the Foxy organization, the endoscopy to the doorstep of everyone. I really wish everyone to understand this vision, how Foxy works. And aim of a Foxy is just to ensure the right deserving candidates to be there. I can see Archana Dwivedi, Bharti, who has the interest to serve the organization. Believe me, organization also needs someone who is on that chair for 3 years, is doing something innovatively, creatively, and reaching out to every common Foxian. So the way webinar has connected us, given us an opportunity to be not only sitting in your comfort room. If you see, it is a IV set which is going on. I don't know whether you can see because my background is blurred, but my IV is going on. That is because I take IV therapies. See, we are aging, and I do believe in preventive and regenerative medicine. So my NAD IV therapy is going on. NAD, please, all of you, you read capital N, capital A, capital D. NAD plus therapy today itself, Google it. It is not available in India, but it is a very important anti-aging. It improves your strength of a mitochondria and cell energy. It delays your DNA damage. It delays your telomere shortening. All this is very important in life. You people see me working so hard because I take this all regenerative therapy, and I'm telling you all because I want all you to age intelligently. It's very important to consider this concept of intelligent aging or reversal of aging, what I say. And everyone should be innovative. We have increased longevity now. Very important. If I want to live 80 years, another 20 years, I'm 60. I need to be as active at the age of 80 as 60. So always have innovative minds. And these are the committee chairpersons who are doing, I can see Subhash, you are working in a modular OT in a beautiful, comfortable atmosphere, but yet being a chairperson, giving time to Foxy. That is what the passion is. You don't want to compromise. We don't want you to compromise the work. I'm becoming Foxy president. I'm not closing down my practice. It's impossible. You cannot do that. But at the same time, remaining in your comfort zone, if you take out little time and give for our Foxy friends who are Foxians, who wish to enhance their knowledge and help the women of their smaller cities, it is great. I do have lot of seniors here, Dr. Uma Devi, Dr. Rekha Rajeshekharan, Rajendra Kumar, Dr. Vidya Bhatt, Dr. Panchan Das, along with youngsters like Richa, Pal and Santwan. Santwan is doing amazing work. 2 years, I know Santwan, he's most dependable anyone can beat on. So we all are proud of you. I can read few name of Yukti, Bharadwaj and all. I know these are the young shining stars and the Foxians of tomorrow who will take the India, the Foxy, the IAG, the ISA to all globally. I wish you all the best and thank you for making me a part of this wonderful team.
Thank you, Dr. Sunita.
Thank you, ma'am. Thank you very much, ma'am.
Thank you so much, ma'am. You join our webinar in wherever you are, whether you are in traveling, you are at airport, you are in Ashray. Now you are taking highway line and still. So the many things we have to learn from you, madam. And thank you so much for always motivating us and supporting us, guiding us.
Subhash Mallya will write a thesis by evening on NAD.
NAD.
For him now he will
Yeah.
do the Google NAD.
Yeah, we
Madam,
just,
It's
I,
fantastic.
Dr.
I'm
Sunita, I
also
just was looking
motivated,
into it.
ma'am. I'm also very motivated that midlife should never come then, and that
Yes.
should be in the picture. Thank you for the support and this new thing, ma'am. Definitely, I should do Google by today.
Google it. It's not
I just
available in
Googled it.
India.
Dr.
Come down to
Sunita,
me in Pune and take it with me.
I just Googled it. Just for information, is it available in India now?
No, no.
Right off.
It's
Not available.
available in India.
Okay.
In India, it's unfortunately not available. I source because I run a preventive and regenerative medicine unit.
Madam, but you are in India now.
I import these, yeah. I import. I don't take even gluten.
Just
Rekha,
wanted
we all will go to Pune. We will all go to Pune.
Yeah.
Thank you.
Thank you.
Thank you, madam. Thank you.
Thank you, ma'am. Thank you.
Now I welcome our another distinguished chief guest, Dr. Vidya Bhatt ma'am, who is a visionary in a field of laparoscopy. Ma'am, we are truly honored by your presence here. We seek your blessings. So, small introduction.
Yeah. Thank you so much, Richa, and thank you, Sejal. Thanks for inviting me to this webinar. You got to say something, Richa, or shall I talk?
Madam has held various positions. President
No, it's okay.
Kasturba.
You put my CV. No, it's okay. Allow me to talk. It's a great feeling to be in this endoscopic webinar. Anything endoscopy is very dear to my heart. All of you know. If you say something else, I say my first love is endoscopy. And when Subhash took over as endoscopic chairperson, I saw a sudden change. He started, as Sunita madam said, he started a lot of workshops, going to nook and corners,
Can
reaching
we
the
stop the
unreached.
screen sharing so that we can see all?
Ma'am, my internet is slow. That is why I'm.
No, close down the
No,
screen
she
share,
can,
no?
Richa
Dr.
can do
Richa,
the,
please.
yeah.
Stop
Stop
sharing.
screen sharing
Yeah.
so we can see Vidya well.
Yeah.
Ma'am, my internet, there's a problem because
No
it's going
problem.
to
We
rain
can
now in
hear you.
Bangalore. That's right. Yeah.
Ma'am, we can see at least your photo now.
Yeah, I'm heard. No, that is enough. So I saw a sudden change and he started reaching the unreached. I think a lot of work has been done in endoscopy in the past 2 years. And the most beautiful thing is endoscopy and IAGE should go hand in hand. And that's happened in the last 3 years. Now, my vision is it should go continue for the next 3 years. And Subhash is in managing committee. Sejal also is in managing committee. And I wish you all the best, Sejal, to take over and start the same work. And same endoscopy and IAG should go hand in hand. I think we should increase the training. We should increase more and more right kind of endoscopy. I would always want to specify that. And I like this year's Dr. Atul's theme of IAG, that is keep it simple, keep it safe. You should do safe endoscopy. And I'm glad that you people are promoting it. So endoscopy should grow not only in India, but our vision should go everywhere, I think, across the globe. That's basically because we endoscopic surgeons in India are very good. That I feel proud to say that. So, and I'm so happy that Foxy Endoscopy Committee is like really doing very well now. So, wishing you best wishes, Sejal, and Subhash, congratulations to you for all the hard work. And I'm sure you will continue to do the work. And we will make you do. Even if you don't want to do, we'll make you do. And Sejal, best wishes. And
Thank you,
I know
ma'am.
you'll do exceptionally well. And thanks for inviting me for this.
Sunita madam will make us continue next year also, madam. So
Yeah,
nothing to
yeah,
worry.
yeah,
That's the same.
yeah. And all the others, Bharti and whoever is contesting this time, best wishes to you. I know you people will do wonderful work. And Bharti is from my state, so I promote Bharti. Please vote for Bharti. Please take care of Karnataka people, because we Karnataka people are so loving and friendly to everybody. So thank you so much. Anyway,
Thank you, Vidya. Thank you.
Yeah.
Thank you, Vidya ma'am. Thank you so much for your kind words, and we are highly obliged to have you here, ma'am.
Thank you,
Thank you, my
Vidya, for
pleasure.
saying that Karnataka people are wonderful. Thank you for that.
Yes,
Though I'm
we are
not standing
wonderful.
for
And
election.
Sunita ma'am will agree with that.
agree.
Sunita ma'am will agree with that.
Yeah. Though I am not standing for election this year, thank you.
But Sunita ma'am will vouch on that we are all wonderful. We love you, Sunita ma'am.
Yes, ma'am. Thank you. That's
Thank
I
you.
very
also
true.
love you, Vidya, and I'm just waiting the day you will take over as a IG president. We'll
Yes,
draw
ma'am. We'll do a
Sure.
lot of work.
Sure.
Yeah, we do a lot of work. And thanks to everybody for supporting me in IAG. I always say that. That love and affection is amazing. Thank you.
Thank you. Thank you, ma'am.
Thank you very much, Vidya ma'am. Thank you very much, Vidya madam.
I'm inviting you all for e-endoscopy. We'll miss Sunita
Yes,
ma'am,
yes.
but all of you please be there in e-endoscopy. 4th,
Yes.
5th, and 6th of
Yes.
October. Yeah.
Yes,
Yeah.
Vidya. Yeah, we're all there.
Yes. Thank you.
We are
Yes.
there.
Thanks.
Yes.
Yeah.
Sure. So now moving on to, I would like to invite our special invitee for the session, Dr. Bharti Rajshekhar madam. Madam is the president of the Karnataka State Obs and Gynec Society. She has held various positions in the FOGSI different committee like FOGSI Public Awareness Committee. She was a member of Preventive Oncology Committee.
Yeah.
She is also having awards, multiple various awards. Madam, I invite you for the.
Yeah. Thank you. Thank you, Dr. Santwan, for that
Thank you, ma'am.
warm introduction. And my pranams to the President-elect, Dr. Sunita Tendulkar, and the guest of honor, Dr. Vidya Bhatt, a close friend of mine. My sincere thanks to Subhash Malya, the endoscopy chairperson, and the 2B endoscopic chairperson, Dr. Sejal, for having me on this platform. And at the outset, I would like to say truly the FOGSI endoscopists are on the global map, and they have made their presence felt globally as well as in the nook and corners of our country. And Dr. Subhash has truly done justice to this by going to smaller societies and telling them, like Dr. Vidya said, stay simple and be safe. It is possible. If Dr. Subhash Malya can do it, Dr. Bharti can do it, and somebody else who is in the small setup in Hassan or in Chikmagalur can definitely take up the simple steps of endoscopy, like the simple procedures, if not the complicated procedures. And taking this forward, Dr. Sejal has put across a very good theme of topics today, talking about hysteroscopy and talking about Dr. Rekha Rajendra Kumar will be talking about endometriosis and laparoscopy and what fertility sparing surgeries we can do. And of course, a very fond subject of Dr. Subhash, I would say, is what are the difficulties you face in laparoscopy? Because whenever we do a procedure, I think we need to know what are the difficulties. So if we are able to overcome the difficulties, we have the courage, and definitely our skill will improve to do these procedures so that we give them the best result to those who come to us in search of a good treatment and relief of their pain. So I also wish all my co-contestants, Dr. Sejal, Dr. Archana Kumari, Dr. Ajna Dwivedi, and myself, who are going for the FOGSI elections, chairperson elections, which will start from 16th to 25th. But at the same time, I would like to put across another message. The FOGSI presidential and the vice president elections are going on. Our vote is very valuable. We can make a difference. I request each and every member of FOGSI to kindly exercise your mandate and see that FOGSI rises to higher levels, and we will definitely deliver good practice protocols, fellowship, friendship, and much more on this FOGSI platform. I'm wishing this webinar a great success. I would request Dr. Santwan to take over the academic session. Thank you very much.
Thank you so much, Bharti ma'am.
Thank you, Sejal.
Yeah. Thank you, ma'am, and all the best to you, ma'am.
Thank you, Sejal. Thank you very much.
Here I can see Pandam sir and Bandita madam also, Dr. Arpit Vachani, secretary of my own society.
Oh, namaste, sir.
Also
Namaste.
here. Yeah. Thank you.
So thank you very much, everyone, for your wonderful blessings of this webinar. So we conclude the inauguration session, and I'll ask Dr. Richa, madam, to introduce the next talk for the session.
Introduce Dr. Archana, ma'am, as a special invitee. I guess Dr. reaches that internet
Oh.
is not there and
Okay,
I
so
find her.
okay.
So
I would introduce Dr. Archana Dwivedi, madam.
yeah, it is our proud to introduce our
Yes, ma'am.
our own dear Dr. Archana Dwivedi, ma'am. Yeah, Richa is here. Yeah, okay.
So I think Sejal, at this outset, I would like to take it over from here. Thank you, my dear friend Sejal. I can being present in front of so many stalwarts with Dr. Sunita ma'am's blessings, Dr. Vidya ma'am's blessings, Dr. Subhash is here with us, who has already marked a place in the world map in endoscopy, and I know Sejal is going to step into his shoes very bravely and do a take it to a newer heights. And Dr. Rekha Madam, your support, Dr. Bharti Madam, and all the other societies who have joined together today to fulfill this desire to work for FOGSI and set up a teaching and taking the knowledge to another level. So I'm very proud, and I'm putting up my candidature for Midlife Management Committee. But before that, I think Sunita ma'am has already triggered the thought to be fit at 40. And that should be our mool mantra for what we learned today. Should go further and to work for a better future and for the better FOGSI. Probably the fitness and keeping yourself younger, forever young, is what I take home today, Sejal. And probably we all will be benefited because the way Madam works, the way Madam puts the things into order, I mean, things become automatically, we start following, and things materialize to a next level. Probably we all are aiming towards the same. And Bharti Madam has beautifully introduced the whole topics and speakers. I won't like to repeat and waste the time from my side. But definitely, it's a proud moment for me. My dear friend Sejal is standing for endoscopy. So endorse your blessings to her because she is the most deserving person. And Dibrugarh Society President, and sir, I can see you, and Navi Mumbai, Shimoga, Surat, Arpit is there, Praful sir is there, Guwahati Society, Bangalore, obviously, Karnataka Society. I think we all, as a Baroda Society, myself and my secretary Reshmi would like to welcome you all for this webinar and wishing a great success to it, and seeking your blessings in my future tenure as a midlife chairperson, Committee FOGSI Elections 2024. Thank you so much for having me here, Sejal and team. Thank you so much. Dr. Santwan, I cannot stop without praising you and Richa, and especially the sincerity and the audacity. I mean, you work so well, and I can see a bright future all together with all of us ahead.
Thank you very much, madam. Thank you very much, madam.
Thank you,
all the
Thank you.
Dr. Archana, in your midlife committee, keep one program on NAD.
I am into that, madam. It is already gone in me. I told Sunita ma'am it's already in. So if given the chance in future, definitely that has to be a talk. I mean,
I already read about it. The injection costs 12 to 22,000 per dose. To be
Actually, the idea behind it, Madam said it so coolly that you should always remain young and fit, because if you want to work and your body is not supporting you, how are you going to supposed to work? So I think that is the beast. I mean, that is the take home which I'm taking right now. I mean, everybody. That is very motivating. Santavan, we are going to look to your age only, even if we
not only take Archana, not only take home, make all of us younger.
Yeah, surely. Would be working towards it, ma'am. Thank you so much for having me.
Yeah, thank you. Thank you, Archana. Thank you.
So after this beautiful inaugural, now let's move on to our session. So our first session is endometrioma and infertility, to operate or not. Speaker of this session is Dr. Rekha Rajendra Kumar ma'am, Chairperson, Dr. Shaila Jayaprakash ma'am, Dr. Bandita Sinha, and Dr. Indra Reddy ma'am. I welcome you all. So, Dr. Shaila Jayaprakash ma'am, she is consultant obstetric gynecologist in JP Aradhana Maternity Center, Shimoga. She is the president. She was president of Shimoga Obstetric Gynecological Society for 2023-24. She has worked as a medical officer at FPI Shimoga for 12 years and have conducted around 12,000 tubectomies. She has worked as a consultant at Kingdom of Bahrain for 5 years. She was treasurer SOGS for 2 years. She was executive committee member at IMS Shimoga for 4 years. I welcome you, ma'am. Dr. Bandita Sinha, she is a chief consultant and fertility specialist at Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. She is director, World of Women Clinic, Vashi, Navi Mumbai. She is a fertility specialist at Apollo Infertility Center and honorary secretary of Navi Mumbai Obstetric Gynecological Society. She has various awards and publications under her name. Her special interest is for fertility treatment, adolescent health, and high-risk pregnancy. Welcome, ma'am. Dr.
Thank you so much for the kind introduction and greetings from Navi Mumbai. And special thank to Dr. Sejal for inviting me on this platform. And best wishes to all the contestants who are for this session of Foxy elections. All the best to all of you and wish a great success for this webinar. Thank you.
Thank you. Thank you, ma'am, for joining. Thank you.
Dr. Indra Reddy, ma'am. She is head of the Department of Obstetric Gynecology, Sagar Hospital. She is former associate professor of obstetric gynecology at Vani Vilas Hospital, Bangalore, and she has worked as a consultant in KSA in tertiary center affiliated to Saudi Board and Royal College for 16 years. She has a teaching experience of 16 years. She is currently honorable treasurer of BSOG. Madam, we welcome you. Now I hello.
Yes, you can. We can
Hello?
hear. Yes,
You're
we
audible.
can hear you.
You're
Yeah.
audible.
So, ma'am, now I request you all to introduce our speaker, Dr. Rekha, ma'am.
Indra madam, you want to say something? She's traveling, madam. Madam, unmute yourself and
Madam, you are mute, madam. Indira, madam, your voice is mute.
we
Please
can
unmute.
see your smile, but we can't
Smile, I
hear.
know. Her ever smiling
Yeah.
face is there.
Yeah, I'm
Welcome.
sorry.
Welcome,
I'm
madam.
very
Traveling.
sorry. I was really, sort of made other program to attend and suddenly realized that, I have to be there as a chairperson, especially to our beloved President, Dr. Rekha Rajendra Kumar. When she is going to talk, me as a treasurer, I cannot miss it,
Thank you.
She's
you
a
so
very
much, ma'am.
dynamic and vibrant president, and sort of I have not got my spectacles to read all the awards what she's achieved and the publications and everything. I
Not
really
necessary.
know Rekha. I know sort of what I'm saying is I'm not able to read it because the glasses are not there. Traveling, please forgive me. And please take over and start the talk. Huh? Thank you very
Yes, ma'am.
much.
You are
Yeah.
looking very nice without glasses. Fine. Okay.
Welcome, madam. Welcome.
Fine. Shall I start? Shall I
Yes,
share?
madam. Yes,
Yeah.
Yes. Let's not
Please.
waste time. Yeah.
Thank you.
I'm sharing my screen. One minute. Yeah. Yes. First of all, I acknowledge my thanks to Dr. Sunita Tandulwarkar, Madam, Dr. Sejal, Dr. Bharti, Dr. Vidya Bhatt, and all the societies who are conducting this program. Congratulations for the success of this webinar, as well as I wish you in advance, all three of you, Dr. Archana, Dr. Sejal, and Dr. Bharti, come out with bright colors. Thank you so much. With that acknowledgement, I proceed with my talk. The talk, what I'm going to do today is on important, I don't know, the screen is getting covered. 1 minute. Yeah, the impact of the surgery in endometriosis related infertility. We are restricting ourselves to the endometriosis related infertility. There is always a dilemma, as all of you know, whether to operate or not. Let me throw some light, though I'm sure the confusion to certain extent will remain even at the end. 1 minute, the screen is not moving. Yeah, William Osler way back said, he who knows endometriosis knows gynecology. You can understand that means it is a disease of controversies. We know that it is a benign disease, though locally lurking. We know that it's an estrogen independent, though there is a lot of role of the progesterone and other hormones. And we know that it is a progressive gynec disorder. And the unique nature of this disease is that it restricts itself to the reproductive age. Whatever problems it is going to cause is attacking on the women of the reproductive age, and they are the target group. Now, before talking about the laparoscopy, the treatment, whatever treatment we give for these infertile women who are suffering from endometriosis, depends upon this entire list, like the age, the obstetric status, the male partner problems, any other problems. Is she suffering from pain? Is that the pain her main symptom, or infertility? So there are many factors that decide our treatment. In this slide, I have just put the two things, the two branches of treatment. There's a medical therapy and surgical therapy. Of course, I'm not going to talk on medical therapy. Let me concentrate and restrict myself to the surgical treatment of infertility in these women. Now, to come to the diagnosis, that is to make a definite diagnosis of endometriosis, the very beginning is the visual inspection. Especially when it is an early stage like 1, 2 of endometriosis, the visual inspection of the pelvis by laparoscopy is the gold standard. All of us use not more than 5 mm scope now. So that is a very simple surgery, but that gives us a direct visual inspection of all the problems there. Unless the disease is visible to you when you are doing a pelvic examination, a dark bluish nodule there, a tender nodule or a scar endometriosis. Other than that, if it is not visible like that, if it is an intrapelvic problem, it is the laparoscopy that is a gold standard of investigation. And I'm sure all of you are going to agree with me on that page. Compared to laparoscopy, TVS has limited value in diagnosing peritoneal endometriosis and deep infiltrating endometriosis. So if it is a very early stage of endometriosis, or if it is a peritoneal endometriosis, endometriotic adhesions, the metastasis, the TVS may not be of much help to us, and it is a visual inspection that gives us a hoard of information. So the with laparoscopy, what are we going to do? We diagnose not only the disease, we also know where all the problem has spread. We stage the disease. There are a lot of parameters. There are a lot of different types of classification. We are not going to talk about that. It tells us about the extent and severity of the disease. One ovary involved, both ovaries are involved. In one ovary, how much of the normal ovarian tissue is there? Is the tubo-ovarian relation altered, etc., etc. So ideally, the laparoscopy, it should not be performed within 3 months of suppression of the endometriosis, like giving Leupride, giving Dynages. Then immediately while the patient is on that, if you do laparoscopy, you may not be able to make the exact diagnosis because of the suppression of the disease. The methodical approach is required. Thorough inspection of the side walls, the ovarian surfaces, the broad ligament, the bladder, the cul-de-sac, the bowel serosa, everywhere you have to check when you have a suspicion in your mind. The uterine manipulation also may be required, because sometimes you may be having a small spot, that's what calls a black or a salt pepper kind of spot there, or there may be a small nodule there in the cul-de-sac. It may be the posterior leaflet of broad ligament, etc. It may be really hiding. When you do laparoscopy, that is the advantage, that you check every part of the pelvis. Photography and video recording also is very much necessary in this medico-legal era, needless to say. So these are the classic pictures of the endometriosis. All of us know the ovarian endometrioma, or the small spots there, the scar, bluish scar, and these are the small spots, etc. But in the next slide, these are also, especially for the youngsters who have logged in today, have a high degree of suspicion in your mind. Your laparoscope should not just go in and go out. That will not serve any purpose. You should be able to make a diagnosis. Keep an open eye with mind suspicion in your mind about endometriosis, like the small white blebs or little scarring here. So all these also may be the endometriosis features. Now let us talk about why to operate, should we operate. Let us, the first few slides are on to operate, next few slides are not operate, and then I come to the conclusion. Now these slides are about to operate, like the points in favor of the surgery. The first line of treatment is excise or destroy the lesion. We don't once made a diagnosis, you want to remove and you want to throw that endometriosis out, because we know that it is going to increase in size, it is going to burrow inside, it is going to recur, cause more problem, and destroy our entire anatomy and physiology of the pelvis, especially the reproductive part. Any endometriotic implant seen during laparoscopy is taken care of. The minimal to mild disease may benefit from surgical ablation, like the small sprinkle kind of, or some gunshot kind of small superficial surface injuries are taken care of by a short small ablations. The pregnancy chances reduces with severity of endometriosis. So mild to minimal to mild endometriosis is always very encouraging, and we are very hopeful about her fertility. Now, which are the cases where surgery is indicated? When these infertile women are not they're outside the bracket of infertility, if they have a very severe pain due to endometriosis or endometrioma, when it is potential for rupture, size more than 4 centimeters, because it may give not only compression of the follicle, it may give problems for the expansion of those follicles also. One side we are giving the gonadotropin injection to expand or increase or the growth of the follicle, but other side the endometrioma is giving pure compression effect, and because of the pressure effect the follicles are not able to grow. Other than that, it can also cause problem like inability during our egg pickup. So endometrioma may come in the way, those which obscure the egg pickup. To improve the access to the follicles, you may have to get rid of this endometrioma. It can also cause follicular contamination, as all of you know. I'm not going to go in that direction of egg pickup in case of endometrioma, etc. If there is concern of occult malignancy, yes, first of all, it should go out of the body as early as possible, because we want to have a histological diagnosis on that. If it is associated with infection or ovarian abscess, again, we have to remove that. Then deep infiltrating endometriosis causing obstruction like ureteric, bowel, etc. Again, surgery is indicated in these cases. Before surgery, counseling is very much necessary in the present era of lot of medico-legal problems. The woman should be counseled regarding the risk of reduced ovarian function after surgery. So we do the pre-surgery and post-surgery AMH. She also has to be explained that the ovary itself, if it totally occupied by endometrioma, that ovary may go. You may have to work with only one remaining ovary. This we have to explain, because what she will think is you have removed the endometrioma and that entire ovary will become normal. But the problem is because of the endometrioma, which has given a lot of problem and destroyed all the tissue there. So the decision to proceed with the surgery should be considered carefully. The woman has had previous ovarian surgery. So case of recurrent endometrioma, be very careful. Think twice before you put your scope. It is almost no in case of recurrent endometrioma where the AMH is very low. Proper counseling is very much necessary, considering all the above factors which I mentioned. So why I am promoting laparoscopy? Why I am saying that we have to laparoscopy? One, I said the indication was pain. So we have to relieve her from pain or any other obstructive symptoms, improve the ovarian response to our gonadotrophins, and when we check with the folliculometry, improve the access to the follicles during egg pickup, decrease the toxicity to the embryos and the gamete. The egg itself becomes toxic if it is bathed in the endometriotic fluid. It reduces the inflammation in the pelvis. Once that endometriotic tissue and the fluid is out, it enhances the uterine receptivity. Our endometrial thickness is also better. Histopathological confirmation, and we don't want the endometrium to progress. So we want to keep it contained. So these are all the advantages. Now coming to the surgery in endometriosis patients with infertility, certain facts what I want to mention is surgical removal gave shorter time to pregnancy and live birth rate with IVF. Conception rates are maximum in the first 6 months. That is why we advise and encourage patients to go for pregnancy as early as possible. Not only we encourage them, we advise them, counsel them to go for the treatment. Can you mute others, please? So we advise the patient to go for IUI, IVF, whatever. Take active treatment of infertility because it is maximum in the first 6 months advantage. American Fertility Society or American Society of Reproductive Medicine say the proper operative laparoscopy increases the pregnancy rate. So it is not the just diagnostic thing. Even if it is a mild or moderate endometriosis, do whatever you're supposed to do properly, like small ablations, etc., so that you destroy that surface tissue, the endometriotic tissue. So the proper surgery is very much necessary. The ablation or excision combined with adhesiolysis of the endometriotic lesions will restore the fertility in most of the cases, especially this is what I was telling, minimal or mild endometriosis. According to RCOG, excision of the endometriotic capsule increases spontaneous pregnancy rate compared to drainage or other shortcut or smaller methods. The presence of the large endometrioma significantly causes problem in the retrieval. Ovarian endometrioma, this is certain studies which I have put, reduce the rate of ovulation in contrast to normal ovaries. A retrospective study on impact of the large ovarian endometriomas on the response to the superovulation for IVF says endometriomas more than 5 centimeter. Usually 4 centimeter is the cutoff what we take. Endometriomas more than 5 centimeter time of IVF significantly decreases the responsiveness. In ovarian endometrioma with the diameter equal to or more than 4 centimeter, cyst excision leads to improvement in access to follicles and it might possibly improve the ovarian response, but again counseling is necessary. Regarding operating a cyst which is beyond 3 to 4 centimeters, surgeon should keep in mind that if all healthy growing follicles may be reached and oocyte collection not hindered because of the presence of this 4 centimeter endometrioma, you can directly go for the egg pickup, not touching the endometrioma. It should not come in your way of the needle, that's all. So then there is no requirement for surgery, even if it is up to 5 centimeter. However, if the growing follicles get obscured, then it may be necessary. The endometriomas, when it is more than 4 centimeter, the problem with the retrieval, what I was telling is, one may be difficult because of the cyst itself. The retrieval may be difficult. You may not be able to see the other follicles which are on the other side of the endometrioma. Added risk of the cyst puncture and contamination of the follicular fluid and ovarian abscess one should not underestimate. Surgical eradication of the minimal or mild endometriosis has shown increased spontaneous IUI or IVF success rates, and all the other results with your treatment soon after the tackling endometriosis is much better. The cumulative pregnancy rate is much better. Now coming to certain facts about which support rather not to operate. The certain school of thought which says don't operate is because they say due to the removal of the healthy ovarian tissue, especially in the ovarian cystectomy. When you remove the ovarian cyst or even during ablation or drainage, don't think that you have removed only the pathological part. Unknowingly, we would have removed, extracted a lot of the healthy ovarian tissue also, unfortunately, and also added to the problem is the vascular injury that can happen when we do the ablation, use our cautery injudiciously, etc. The surgical removal of the endometriomas can prove to be damaging to the ovaries. So you might have removed not only the endometrioma, you might have removed a significant chunk of the normal ovary, which has a good number of nice follicles. So that reduces in reduced ovarian reserve. That results in reduced ovarian reserve. According to different studies, after surgical removal of endometriomas, there has been a reduced response of the ovaries. Remaining follicles also, they may not give an optimum response to your ovulation induction drugs. The negative impact of the surgery, what happens with surgical excision or ablation is one has to be more cautious on the evidence that less is more. In the sense, you have to do the surgery, you have to do the perfect surgery, you have to do the adequate and optimum surgery, but restrict yourself to only the pathological part. Don't do a radical surgery. It is not you're worried about the recurrence. You're more worried about the fertility in these women. That is what you should keep in mind. The absence of plane of cleavage can happen sometimes, and that can result in recognizable ovarian tissue being excised together with the endometrioma cyst wall during stripping, and healthy ovarian tissue removed by stripping the cyst wall was found in 97% of the cyst specimen, and that is a huge number. And bigger the cyst, more the removal of the ovarian tissue. Coagulation or hemostasis can damage blood supply. The negative correlation is with the stage of endometriosis, chance of pregnancy is less. Surgery close to the ovarian hilum should be avoided, because again, you will give a vascular insult to that ovary. So ovarian damage after the surgery reserve, after the surgery, ovarian reserve, I mean, after the surgery is related to size of endometrioma, which I have already reiterated. Ovarian damage is both not only qualitative, it is quantitative also. So it is not just the number of follicles, your AMH also drops. So outcome of the repeat surgery is worse. So that is why I said recurrent endometrioma, as far as possible, don't operate. In IVF ICSI cycles, what happens? Reduced ovarian response on stimulation. So controlled ovarian stimulation needs more of gonadotrophins because they become inert, not responsive to these smaller dose of gonadotrophins. The reduced estrogen level, 13% risk of severe ovarian damage also can happen. So these are all the negative aspects of surgery. So although ovarian endometrioma per se could be detrimental to the ovarian reserve, the current evidence indicates an even lower ovarian reserve observed after the surgery. So in specific circumstances only, you have to operate. We be very judicious, like pelvic pain or big endometrioma, what I was mentioning, difficult to access follicles, but not in all cases of endometrioma. Even if they are 3 to 4 centimeter, if patient is asymptomatic, if you can reach those follicles, don't touch. Finish a fertility part, and then you can think of the surgery. So surgery should not be offered to every single patient who has come with endometrioma. That is what I was saying. So although the surgical excision gives a satisfactory pregnancy rate, the concern about the removal and the ovarian reserve is there. So lap cystectomy before controlled ovarian hyperstimulation does not appear to improve fertility according to some papers. Asymptomatic endometrioma, don't touch. Take her directly for IVF, make a diagnosis, take her directly for IVF ICSI, and then you can touch those endometrioma. TVS aspiration may be considered in some cases just to debulk the ovarian endometrioma, that's all. Beyond that, you will not be doing much benefit to that patient. Now coming to the limitations of the surgery. One, there is a high risk recurrence. I will tell you which are the surgeries which give more recurrence and which are the kind of surgeries give less recurrence. 25% at the end of 2 years and 40 to 50% at the end of 5 years overall. So about 40 to 80% of women have pain within 2 years of surgery. So it's around the corner. It comes back in no time. Maybe about 2 years, it comes back. Unable to reverse the inflammation in spite of doing a proper surgery, post-operative medication is required, and so you may postpone her pregnancy. So small endometrioma less than 3 centimeter with a short period of infertility, give her medical management. In infertile women, the endometrioma less than 3 centimeters, there is no evidence that cystectomy will help. Suppose it's more than 3 centimeter endometrioma, laparoscopic cystectomy is the first line of choice. If it is coming in the way of whatever I mentioned, the coming in the way of follicles, pain, etc. Then you can put the patient on GnRH and block for 3 to 6 months and then take for IVF ICSI. So this has proved to be a successful combination. Surgery is better avoided in the summary of that slide would be the older patient, because you all know that the reserve is much less, the ovarian reserve. I mean, the AMH is much less, maybe most of the times it's less than 0.5. Asymptomatic patients with low ovarian reserve, bilateral endometrioma. When you operate, ultimately will have hardly any ovarian tissue which is healthy. Recurrent endometrioma, again, the surgery is to be avoided as far as possible. There are certain other methods which I was mentioning are the conservative methods like excision or ablation reduces the pain. Excision rather than drainage or fulguration provides better pain relief, reduced recurrence and histological diagnosis. That is, remove the entire capsule of the endometrioma. So ovarian endometrioma less than 4 centimeter, aspiration, irrigation, etc. These are certain kinds of surgeries that can be done. More than 4 centimeters, cystectomy is recommended. I have put here the slide. It says there are other methods of surgery. Also, this is for time being. In women with stage 3 or stage 4 endometriosis associated infertility, conservative surgical therapy with laparoscopy will prove beneficial. If they fail to conceive following the conservative surgery or of advanced reproductive age, then think of going directly for IVF. Resection or ablation rather than drainage should be considered as surgical management, and resection is the preferred one. We want that endometrioma tissue to go out. Downregulation, ANTAC protocol, ICSI, freeze-all, then operate for endometrioma, and then the FET is the proper sequence of how to handle these infertile women who have the endometrioma. However, in women undergoing IVF, when excision becomes difficult because of poor surgical plane between the cyst wall and the surrounding ovarian tissue, then incision drainage. These are all the less opted method, but they are the temporary methods so that you can do something than not doing anything. So the chances of endometrioma recurrence is more with ablation. The purpose of reproductive surgery in this context is to improve the fertility, as I have already mentioned. The two boxes mention about the comparison between the ablation versus cystectomy. In ablation, it is not a radical method. It is just a temporary, or you can call it as a less effective method where the complete endometrioma is not removed. It is the cyst wall is just ablated, but we are not excising the cyst wall. Diathermy is more used. There is less bleeding because you have used diathermy judiciously. You have to use because you are ablating the tissue there. The proportion of the follicles may be destroyed because of your ablation. Lesser loss of primordial follicles because you're not removing the chunk of the ovarian tissue with the endometriotic capsule. Since you have not eradicated this problem totally, there is a higher chance of recurrence compared to cystectomy. In cystectomy, the internal cyst wall, when you have a proper plane of cleavage, you will remove the entire endometriotic cyst completely. Diathermy is less used because you have got the proper plane of cleavage. The proportion of follicles may get lost, as I have mentioned in the previous slides, and there is a more loss of primordial follicles, less chance of recurrence because you have done the ultimate and the exact surgery. Now, visible endometriosis, for that, the surgery should be done. And the types of conservative surgery, what I have mentioned is drainage, the aspiration, incision and drainage, irrigation, the ablation, the cautery, destruction of the internal wall with carbon dioxide laser or bipolar, using bipolars, adhesiolysis so that you maintain the tubo-ovarian relation, destruction of the peritoneal lesions, the GnRH agonist, pre-surgery or post-surgery, and second look laparoscopy. These are all the conservative methods of surgery, unlike the previous surgery which I was mentioning about the endometriotic cystectomy. So the cyst aspiration, no statistically different response is seen with or without the cyst aspiration. So aspiration, the small cyst before stimulation is not necessary. Don't do it. Just for the sake of doing it, don't do it. It is reserved for the recurrent endometrioma where you cannot do a radical surgery again. In those kind of women, you can restrict the smaller kind of surgeries like the cyst aspiration. Sclerotherapy, some people are very happy, some people are just not happy with the ethanol sclerotherapy. It decreases the recurrence rate of endometrioma without altering the results of IVF according to certain papers. Destruction of the cyst epithelial lining with the subsequent inflammation and fibrosis, that is the modus operandi that will eventually result in obliteration of the cyst. The clinical pregnancy rate was same in both cystectomy and sclerotherapy in some clinical trials. Again, there are a lot of papers which say cystectomy is much better than sclerotherapy. Other papers which say sclerotherapy is much better than cystectomy for the different reasons which I have already mentioned. All the above have risk of incomplete surgery. The temporary methods or the ad hoc surgeries which I was mentioning are known to have a risk of incomplete surgery. But excision and cystectomy is the final surgery because it is the complete removal of the tissue, and that is why there is less recurrence. But that results in more reduction of the ovarian reserve. So coming to this slide, whether to operate or don't operate, the advantages of operate is better IVF success. It is the same thing putting in a nutshell. It prevents rupture of the endometrioma, facilitates the oocyte retrieval, avoids contamination of the fluid, the follicular fluid, occult malignancy. You have a histopathologic diagnosis and prevents progression. Don't operate. The school of thought supporting factors are cystectomy prior to IVF does not improve the pregnancy rate, surgery anesthesia risks, potential reduction of the reserve of the ovarian function, aspiration prior to IVF may be tried. There is no increase in pregnancy rate. Now, this is all things what I have mentioned put together in nutshell, the expectant management and the surgical management. Let us talk about, the last few slides, the expectant management, the potential benefits of the expectant management are: it avoids surgery, so no risk of anesthesia, surgery, whatever. No further compromise on the ovarian reserve because you are not touching that ovary. How much of a reserve is there, is there. It avoids delay in commencing the ART. Then a potential risk of that is expectant management, is a pain of the various presentations because of whatever problem the endometriosis has caused will remain. This cyst rupture can happen anytime because you're not tackling that huge endometrioma, can result in abscess during the egg pickup and infection, the same thing. The no histological diagnosis because you have not done anything and may accelerate. So these are all the risks of the expectant management. Now coming to the surgical, you are taking active measures, you are taking that patient for the laparoscopy. What are the benefits? It alleviates symptom because you have taken correct measure for her problems. This logical confirmation is there, decreases the risk of cyst complication, which I have mentioned previously. It facilitates the ovarian access during OPU because of the debulking of the ovarian endometrioma. But the risk of the surgery and anesthesia itself, decreased ovarian reserve, post-operative additions can happen. And because you have done surgery, you may tell your patient to wait for some time, or the patient herself may take rest for some more time, which is not necessary. And as I have mentioned, she has take active treatment, not only the passive treatment at home, active treatment for fertility directly. Most of the cases are for IVF itself, because the first 6 months maximum fertility and the advantage of surgery. The preoperative GnRH agonist we do use sometimes to reduce the size of the cyst and reduce the inflammation, vascularity, adhesion, the cyst wall thickness, etc. The surgery for pain relief, there are certain kind of surgeries which are mentioned, like the rectovaginal, rectal, and uterosacral lesions may need surgery, and the abnormal anatomy and adhesions also may need surgery. There are different methods of surgeries, like for the pain relief in these infertile girls, the ablation of the endometriotic lesion reduces the endometriosis associated itself. There is other methods like laparoscopic uterine nerve ablation, what we call as LUNA, or even other methods like presacral neurectomy. These are all the different surgeries for the pain relief. The recurrent endometriosis, what are you going to do? I am going to take her for a medical management as far as possible. Suppose she does not respond to the medical management, the huge endometrioma has come back, the conservative surgery than definite surgery is the one which we want to do. And it is indicated, as I said, if medical therapy does not help, or the cystectomy or adhesiolysis may be an option in these women. So there are different guidelines like the American Society of Reproductive Medicine, all which I have already mentioned. This slide is important, and rest of the guidelines I'm not going to go in detail. The age of the female, the duration of infertility, stage of endometriosis, and presence of associated symptom. For all the important points should be considered while formulating the management plan. For women of age 35 or more, intense infertility management such as IUI or IVF should be considered. The American College guidelines, there are so many other, American Society of Reproductive Medicine, RCOG, French College of Infertility, ISHRE guidelines. There are so many guidelines, but all these facts I have already mentioned just to show that there are so many guidelines, but again, there is still the confusion among those guidelines only. So that is why I have shown the different guidelines there. I have come to a very last slide of mine, and I would conclude by saying laparoscopy is the gold standard for diagnosis. Respectful handling of the ovaries, whatever kind of surgery you're going to do, definite surgery or a suboptimal surgery, it is the respectful handling of the ovaries. Very necessary. Big endometrioma, cystectomy is the proper treatment of choice in spite of lot of pros and cons about each surgery. Avoid surgery on recurrent endometrioma and favor medical therapy or encourage for IVF as far as possible. Post-op adjunct treatment for secondary prevention also one has to consider and should not forget. In stage 3 and 4 disease, operative laparoscopy increases the pregnancy rates compared to the expectant management. Thank you one and all for your patient listening. I hope I tried to clear the confusion as much as possible from my slides. I stop sharing here. Thank you.
Thank you, ma'am. It was an excellent presentation, and you have dealt with all the confusions related to endometrioma, whether to operate and not to operate. Because as a fertility specialist, we want that the ovarian reserve should be adequate, whereas the endoscopic surgeons, they are in a hurry to take out the endometrioma. So we have to be very individualized when we are treating a patient, seeing her age and the symptom. If the patient is young and we can wait for the fertility, or very young and adolescent, we have to be very, very careful what we are going to do, because ultimately it is going to reduce the ovarian reserve. So we have to be very careful, and it should be done in the best of the hands. Secondly, if the patient is elderly and she is going through a severe endometriosis, it is always better to go ahead and do the IVF rather than removing the endometriomas. Any endometrioma which is not painful should not be aggressively removed. We should mostly think about the fertility part. So it was an excellent presentation. I hope everybody enjoyed this. Thank you, Anna.
Thank you so much, Dr. Bandita. Anybody wants to give any input or add to confusion, asking more questions?
Ma'am, endometrioma is always an enigma, and you clarified to maximum, ma'am, in detail with a crisp manner. Thank you so much.
Thank you. Thank you so much.
Excellent, ma'am.
Thank you.
Great talk, Rekha. Proud of you.
Thank you. Thank you. Thank you so much, Bharti. Bye.
Thank you, ma'am. It was a wonderful presentation, very informative. I
Thank
would
you.
like to thank all the speakers and the speaker, ma'am, and all the chairperson. Now, I would like to Dr. Santavan to move on to the second session and introduce the chairperson and speakers.
Okay, so after the very insightful lecture by Dr. Rekha Madam about the endometrioma, we go on to the second session, that is the hysteroscopy in infertility. The speaker for the same is Dr. Sejal Naik, madam. And I would like to introduce our chairperson for the session, Dr. Panchan Das sir, Dr. Jyoti Baby madam, and Dr. Uma Devi madam. Just a minute. Okay, Dr. Panchan Das sir is a professor of Guwahati Medical College, and he's the president of the Guwahati Obs and Gynec Society. He is also president of the Northeast Obs and Gynec Society. Welcome, sir.
Welcome, sir.
Thank you so much for joining, sir.
Welcome, sir. Thank you for your presence here. Such a senior person. Thank you.
Sir, you are on the mute mode. If you remove it.
Yes, please, sir.
Namaste, sir.
Yes, sir. You are audible, sir.
Sir, just host, you can move the unmute part, sir. Help him doing that.
Sir, unmute will be on the left corner down first. You are unable to unmute, sir.
Is it okay if I talk about your topic till sir joins?
Dr. Santwan, please.
Okay,
Yeah.
so I
He
introduce
can
the
talk
other.
to sir and yeah, it will be better because
Yeah,
So
sir
I'll-
is
yeah, he
unmute.
can talk to sir directly. Meanwhile, I'll introduce about her topic. And I'll speak about history.
Okay,
If
so
it is
I'll introduce the other chairperson for the session.
yeah, no.
Dr. Jyoti ma'am, she is the president of the Navi Mumbai Obs and Gynec Society, practicing for 31 years in Navi Mumbai, and she is consultant at Anuja Nursing Home, Apollo Hospital, and Kokilabin Hospital. Welcome, madam.
Welcome, madam. Thank you so much for joining. Jyoti ma'am, you are mute, ma'am. Still you are mute.
Okay.
Yeah,
Good
yeah.
evening, everyone. Yeah, is it? Am I audible?
Yes,
Yes,
ma'am, you're audible now.
Thank you so much.
Yeah, good evening, everyone, and thank you so much for inviting me to chair this webinar. Actually, as all of us know, that complete workup is essential part of infertility management, and hysteroscopy is sort of gold standard investigation to diagnose multiple problems like adhesions and malformations, submucous fibroids, and even endometrial polyps. And it is the best tool in the best hands, like Dr. Sejal. So I think it is the apt introduction of you as well, and I request you to start your lecture. But before that, I will like to wish you all the very best for future, means this upcoming election, as well as all other contestants, because they are really working very hard, and I really wish them all the best. Thank you so
Thank
much.
you. Thank you so much for your kind words, madam. Thank you.
Thank you, Dr. Jyoti.
I would also like to invite Dr. Uma Devi madam. She's a professor and head of Obstetrics and Gynec Society at the Santosh Hospital, Bangalore, and she had various awards and prizes to her credit. Welcome, madam.
Thank you. Good evening, everyone, and thank you all, and especially Dr. Sejal for inviting me to be the chairperson for this wonderful session. And we all know that hysteroscopy is a wonderful investigation for infertility, but there are so many pros and cons, whether to remove small polyps or to leave them alone, what to do with the fibroids, and what to do with the uterine abnormalities. Should we operate on all these patients, or just we can wait and watch, whichever is the best method. And Dr. Sejal Naik is a person who has so much experience in this infertility and endoscopic surgeries, and very happy to chair your session, and we would love to hear from you. Thank you.
Thank you so much, ma'am.
Wish you all the best.
Thank you. Thank you. Your blessings, ma'am. Thank you. I couldn't meet you, ma'am, personally because of last moment. My flight cancellation because of some accident in Delhi airport. So I missed that wonderful conference at Bangalore.
But
Thank you, Sejal.
thank you.
Yeah.
Thank you.
Yes, ma'am.
We'll
Yeah.
be hearing you now.
Yeah, so
Thank you.
that's why this online platform has no restriction. We all can meet each other. So
I know myself, Sejal tried all the ways out to reach Bangalore, but couldn't.
so
Thank you, Jyoti ma'am and Pancham sir, for the wishes. Thank you so much.
thank you, Pancham sir, for joining, sir. So
Thank the co-chairperson, sir. Thank you.
yeah. So shall I share my screen now? Yeah. So let us move ahead without wasting much time. So thank you once again, Foxy Endoscopy Committee and all the Foxy's member societies for joining today for this wonderful academic meet. And I really thank Chairperson or Subhash Malia for giving me this opportunity and the platform to connect with everyone with some knowledge sharing. So today I'm going to discuss about the hysteroscopy. Before performing any operative procedure, one must do the good ultrasound. Ultrasound plays a very vital role here to diagnose the pathology, to decide the complexity of the surgery, and to explain the patient in thoroughly regarding the outcome, what she can explain following the procedure, whether she will require 2 sittings or 1 sitting, how will it help her in achieving her future fertility, and many other things like your preparation in the OT and your equipments, instruments, your staff, whatever you require, so that all can be done by the ultrasound and be preferred to do the ultrasound by the surgeon himself or the herself, so that the accurate diagnosis and the complexity can be judged by. So one of the common indication in fertility with the which requires the hysteroscopy is the previously attempted IUI or ET catheter, which was unable to negotiate through the internal os. So stenosis os is one of the indication where we can try to negotiate the hysteroscope under vision, and or if it is not possible, then the ultrasound guided this procedure can be done, where you do the irrigation. There will be separation of the myometrial layers that suggests that you are in wrong plane. So then you can withdraw your hysteroscope and visualize the endometrial canal on ultrasound, and then accordingly you can go more anteriorly or the posteriorly, and then you can find out the correct passage. So this is a way how you can negotiate your under vision, the hysteroscopic vision, under the ultrasound guided hysteroscopy. If internal os is stenosed, then one can hold the cervix with the Alice forceps or the valcellum and pull it, so that the acutely anteverted this uterus will become a little straight. That will correct the angle between the uterus and the cervix, and which will make the easy negotiation of your hysteroscope. If it is not possible, then one can remove the external sheath, and only with the irrigation fluid and an inner sheath one can negotiate. That will reduce the diameter of your assembly. Even if that is not possible, then one can use the polypectomy forceps at the internal os. Just while you are in the cervical canal, just wait for a few minutes so that the irrigation fluid that is going there with the flow, with the force, will open up little bit the internal os. Then you will be able to see the pin, and then you can introduce your polypectomy forceps and open it a little bit mechanically, so without damaging much. If even with the polypectomy forceps it is not possible, then one can use the scissors to cut around a little bit fibers of the internal os, and then you can please mute us. Yeah. So then you can insert your hysteroscope very well safely inside the cavity. One can also use the vasopressin intracervical, which will fasten the entry. Next, another indication for the hysteroscopy in infertility is the tubal occlusion. While we attempt to open the tubes, the infection is being one of the most common indication reason for the tubal occlusion and the reason for the infertility. The severe the infection, the more chances of having the tubal occlusion, and the more the number of the episodes of salpingitis lead to more chances of tubal occlusion. So here the tubal cannulation is play a very important role, where we do first we try to do the laparoscopic methylene blue test, chromoperturbation. If the dye is coming, then no need to do the this tubal cannulation. Sometimes in HSE you may have the report of cornual this complete tubal block or the cornual block because of spasm at the cornum, as the HSE is not done under anesthesia. So if there is no free dye comes, then only we do the insert the novice or the cannulation catheter through the ostia, and then you pass the guide wire just to the interstitial part of the tube. Don't go and pass the guide wire through and through the entire tube. That will cause more damage to the cilia of the tube, just to the interstitial part. And then once that is visualized under the laparoscopic view, then you do the selective chromoperturbation of that tube, and this can be rewarding, as the salpingitis occurs in an estimated of 15% of the reproductive age women, and it has been said that 2.5% of the all women, they become infertile as a result of salpingitis. So this is one of the common reason of infertility. Intrauterine adhesion or the synechia, where the hysteroscopy is the gold standard for diagnosis as well as the management. The pregnancy rate increases around 74% post-procedure, depending upon the degree of synechia, which is much more higher than the found in untreated patients. So the complete plastered uterine cavity has a very poor prognosis, where the infection and the this previous DNC or previous abortions may have lead to the synechia formation, and which can be diagnosed ultrasonographically either in 2D, 3D or with the sonohysterogram, and the procedure can be planned. Here the patient may require 2 sittings or 3 sittings with the hormonal supports, high dose of estrogen following the procedure, so that the endometrial growth can be promoted. This is one of the challenging procedure, where because the anatomical landmarks are being lost and there is a high risk of false passage and the perforation. So intrauterine devices, foreign bodies that are lost inside the cavity, or the forgotten devices, can be easily removed with the hysteroscopic way, and simultaneously small polyps like this case can be removed easily with the cutting with the base, with the pedicle, with the scissors, removing from the very base, which reduces the recurrence rate of such a polyp if it is removed from the very near from its base. The vertical arm of the Copperty device and the polyp can be held with the polypectomy grasper, and the entire assembly is to be removed through the uterus and the cervical canal, so that the specimen we can remove from the cavity. Polyp is found in 2 to 3% of the infertile women, and in 24% of the symptomatic women. It is associated with the poor reproductive outcome, and it is recommended to remove these polyps in patients with the infertility. And also it includes the polyp can reduces the live birth rates and increases the miscarriage rate. And after the polypectomy, the pregnancy rate has been found to be increased by 63% compared to if not removed, that is the 28%. So small polyps like previously shown can be removed with the mechanical force with the scissors, but in such a polyp like that is a very long type 0 kind of polyp, elongated, pedunculated polyp. If we remove from the base, the specimen removal, this is 2 centimeter from the internal os, will be very difficult. So we need to slice it down into small pieces with either resectoscope or with the scissor, depending upon the consistency and the size. And then the pieces can be removed through the cavity easily. The fibroids, as we all know, are one of the common benign tumor, and its role as in infertility solely as a causative factor is not very well known. Only 2 to 3% of the women as the fibroid, which are causative of infertility and also the recurrent pregnancy losses. Approximately 5 to 10% of the infertile women have these kind of tumors, and they are significantly reduce the pregnancy rates according to certain studies, and especially those who are submucous, that are the pedunculated tumors type 0, and as per the FIGO classification, type 0, which is pedunculated inside completely, type 1, which is like more a major portion is inside the cavity, type 2 is major is intramural, and so on. Here the type 0 and type 1 are definitely can be easily managed with the hysteroscopy. Now sometimes when there is sometimes this kind of fibroids which are not visible on routine diagnostic hysteroscopy, where the intrauterine pressure is high. So, but when we reduces the pressure, have the habit to have the inspection of the cavity while even after your complete inspection, reduce the pressure and see for the bulge. So as soon as we reduce the pressure, the bulge is coming inside. Here is very important role of pre-operative ultrasound. So which the size and the site has been located very accurately. On laparoscopy, if there is bulge there outside, easy to identify, then this kind of fibroids better to remove through laparoscopy. But it was not, so we decided to remove hysteroscopically. So under low pressure, we just mark the site of the fibroid with cold knife or with the scissor. Then you increase the pressure. And then you activate the resectoscopic loop and start shaving. Once you keep on shaving it, you may able to see the white shining tissue, that is the fibroid. Intermittent reducing and increasing the intrauterine pressure will cause the uterine vasculature contractions and push the fibroid inside the cavity. So that will ease in your surgery. One can also use the myoma screw that is hysteroscopically available to remove this kind of fibroids. So that will pull, we can pull it inside the cavity. But for resection, you need this working elements for shaving off. At near the base, you can see the capsule of the fibroid that is very pink in color. You can easily identify. Better to use this cold knife by scooping it out. Without activating the current, you just scoop this fibroid inside the cavity, and like enucleation with your traction, once it is detached, it is like lifted up, then it is easy to shave it off without damaging much to the normal myometrium. So this kind of deep-seated fibroid can also be managed in expert hand hysteroscopically, and the hemostasis can be achieved under low pressure with the ball electrode and go by the coagulation. So hysteroscopy has the wonderful role to play in submucous myomectomy. For uterine septum, as we all know, septum resection is important in recurrent pregnancy losses that increases significantly the pregnancy rates up to 80 to 90% and the live birth rates by 53-54%. And the post-pregnancy rate improves like post-surgery, and live birth rates improves to merely 10 to 15%. So significantly that lower number of pregnancy after hysteroscopic metroplasty is maybe because it reduces the miscarriage rate drastically. Its sole role as in causing the causative factor of the primary infertility is controversial. Septum per se may not cause the infertility, but definitely removal of it is beneficial for those who are undergoing IVF, and especially for those who have no other known causative factor of infertility. So just by seeing the septum, with the fertility concern couple, we advocate for removing those who are going for the IVF. So septum can be complete or incomplete septum, and 3D ultrasound has replaced the MRI in majority of the cases to differentiate between septum and the bicornuate uterus. So incomplete septum can be incised in the midline with the scissor or bipolar needle, while the complete septum is perforated from one cavity to other side with the Collins knife. With one side, we can put the dilator or the 8 numbers Hagar's 8 numbers Foley's catheter, and then septum can be perforated from one side to other cavity at the lowermost part near the lower segment where it is the thinnest, and then further resection is easy, just like the incomplete septum. For septum, under correction is better than the over correction, and the cornua, as we all know, is if they are seen in a single line, while our scope is at the internal os, is the end point of the procedure, and simultaneously laparoscopy will guide and will prevent us for perforating the uterus. Now, adenomyosis, as we all know, with increasing age, the prevalence with infertility of adenomyosis is increasing. Like with more than 40 years, it's around 25%. And this kind of cystic adenomyoma bulging inside the cavity with the recurrent implantation failure can be easily managed with the resectoscopic excision of this adenomyoma, where exact site and location is to be measured preoperatively. You can see there is a chocolate color fluid coming out with a cystic lesion of adenomyoma, and the fulguration of the active endometrium has to be done at its base, and then followed by the simultaneous attempt is to be given for the future embryo transfer in this patient. Now, approximately 7% of the women with endometrial cancers are below the age of 45, and increasing the age of conception with the recent generation has increased the incidence of malignancy in infertile couple. So, these are the hysteroscopic procedure where we do not do in non-malignant cases, but the accidental finding or the patients were taken for the removal of the polypoidal mass and turn out to be malignant. But these are the typical signs or typical signs of the malignancy can be noted down here with the polypoidal papillary projections, some calcification, friable tissues with so much of vascularity and pinhead kind of vessels, acutely angulated vessels. These are the typical diagnostic signs of the endometrial malignancy. And though the histopathology is compulsory, but the prognosis can be explained and the patient can be mentally prepared with this kind of findings of the endometrial malignancies. So hysteroscopy, PRP, or the stem cell therapy, as it is still recent, and the many evidence are still lacking to promote it in the routine practice. But many of the centers are doing studies over it with the some results of in 75% of the patients having the more than 7 mm of the thickness following the PRP procedure. This we can perform under the hysteroscopic guidance with the ovum pickup needle. We inject the PRP solution. We activate it just prior to the injection, and that is to be done in transfer cycle in day 5, 6, or 7, and the PRP is injected in subendothelial layer, and it is expected to increase the endometrial growth and thickness in next cycle where the embryo transfer has to be followed. But the many evidence are still need to support this procedure as a routine way. So hysteroscopy is an answer to variety of fertility issues. It's an art of ART. It is very safe procedure with complications rates less than 2%, but still only 30 to 40% of the gynecologists, they perform this operative procedure, maybe because of lack of training, fear of complications, or maybe they have attempted but had the failed previous attempt. But the cave we fear to enter holds a treasure we seek. So surgeon skills here remains the best safety measure for the all operative kind of hysteroscopy. So get yourself trained well with the experts, and that is way we can proceed further in our academic career. So thank you so much for patience listening. And here I once again appeal for my humble request to kindly support me for the chairperson post of endoscopy committee. FOGSI elections are about to start on 16th of August onwards. Thank you so much. I'll stop sharing. Have I stopped sharing?
Yes, yes.
Yes, yes.
Thank you very much, Dr. Sejal. It was a very lucid presentation. You've clearly shown where we stand in each of these procedures for infertility. It was wonderful. The video shows everything wonderful, and it depicts the work you're doing as well. So I just wanted to know what about endometritis and the visualization of that through the hysteroscopy in case of infertility. Some of the patients they have secondary infertility or even primary infertility. They may be having endometrial COX or any other non-specific endometritis.
Yes, ma'am. Chronic endometritis is again one of the common cause. And unfortunately, I don't have the typical findings that suggest the chronic endometritis, that video, because it has some variable presentations, multiple small micro polyps there, or maybe label it as a pale endometrium or hyperemic endometrium. It is very subjective, madam. If your pressure of intrauterine volume pressure is high, then it will all appear very pale. If your pressure is very low, then it will all appear very hyperemic. So we rely on the gene expert study or some other diagnostic method also along with the hysteroscopy.
Okay, thank you very much.
Sejalben.
Yes, ma'am.
Sejalben.
हाँ जी, भूपेश भाई કેમ છો? અવાજ સંભળાય છે, દેખાતા નથી.
What is your experience regarding the PRP in endometrium?
Sir, I have done only handful numbers of patients, and what we did is the monocellular PRP that we do in previous cycle of the embryo transfer, where the persistent thin endometrium is there and where all other modality, all cocktail therapy has been failed. Then we explain these patients that this is still under investigation. There is no data supporting the outcome of this procedure, but still we can give it a try as it's a very bad thin endometrium. But what I have observed is in like Asherman patients, it has little benefit in growing the endometrium, but not into the implantation. The thin endometrium otherwise per se, without Asherman or without intrauterine adhesion, may have the better pregnancy outcome following the PRP, hysteroscopic PRP. But that is not sufficient data to give any concluding mark. Probably those patients have the better embryos that can also balance the endometrium. So it is a logic, but we need to collect many more data to prove its efficacy.
Sejal, how do you put this subendometrial PRP? Like I give 4 places, what they say 9 o'clock, 3 o'clock, like that. But some people say do it in multiple places.
Madam, actually what happened when your irrigation fluid is on and then when you inject it, then it will drain out again. So
no, but what we do is after we push, we keep the needle there for some time.
Yes, but once you,
So
there
that,
is a hole there, it's just a logic, madam. If you again re-irrigate, then it will drain out. So what we do, we inspect the entire cavity. Once the patient is painted, wrapped and ready, before taking the patient to OT, we collect the blood. It will require 20 minutes around to prepare the sample. So by that time, painting, wrapping, anesthesia, everything will be ready. Then once we do the diagnostic hysteroscopy, that is also done and normal. At that time, we activate. We mix the activator. And then we take it with the ovum pickup needle and we just remove we locate the needle, we pierce the needle, and then we remove the irrigation and then we inject and just come out. That's all.
Only one place you prick, is it?
Yeah, only one place. And that is just so that our purpose is it should stay there.
Okay.
And
So that
few of the surgeons, they just
after that,
give it intrauterine only, because while doing the hysteroscopic, there is some erosion of the endometrial layer and it will automatically go to the subendothelial layer. So you may not need to inject it. That is what they say. Your hysteroscopy or your hysteroscope itself is eroding a bit of endometrium. And actually, we don't know exactly are we going to the subendometrial layer or the myometrial layer in hysteroscopy. So some are advocating it to do under good ultrasound also.
Yeah, but that needle tip, what we see magnified till that end, that much will be subendometrial only when we push
Yes,
it.
if the
It
bevel
doesn't
is
go
that,
myometrial.
yes, the bevel is so small
yeah.
that should stay in subendometrium. But for the thin endometrium, even that layer in the early follicular phase, it is still very thin.
And we are supposed to we see that bleb of that tissue. I mean the fluid. Then after I keep the needle for some time, say a few seconds, then I remove. I know, of course, that fluid irrigation and all is there, but that's how I do it. Okay,
Madam,
thank you.
it needs to be standardized yet. So everyone is doing for the in a good faith of patients. So they have all developed their own ways of doing it.
Yeah, somehow I am getting good results for thin endometrium.
And multiple punctures, I would not go single. I go with, as Rekha madam said, though done in a few cases only. So
Yeah.
3 points you have to select, and as you said, bleb forming and keep the needle for a longer period. So that ensures us mentally that we have done a good job and results are coming.
Something.
Something.
Yeah.
Thank you so
In the
much.
pre-HRT cycle.
Any experience on lateral metroplasty?
Madam, I am not doing it because I have not come across the typical T shape of uterus. That is the indication for the lateral metroplasty. Otherwise, left and right cutting is very simple, but the patient should be benefited with whatever the procedure we are doing. So the DES exposure is no there now, and I feel it is lateral wall is indenting. It doesn't justify additional procedure. Yes.
I think certain things we have to leave them alone.
Exactly.
Better
They
prognosis
conceive,
than
madam, they
interfering.
conceive. If the uterine cavity
Yeah.
volume is good, na madam, they conceive. There is no issue. But septum we do, madam. Septum, we do not ask them to go conceive, abort, and then we'll do.
Okay.
If we see the septum, we advise to do.
One patient came to me with a scan report 3D only. One place said it's a bicornuate, one place said septum, one place today they got one more place 3D, they said arcuate uterus.
So that is why, madam, do your scan by yourself.
No, I did, but I wanted a 3D scan. So I had wanted my infertility scans, I do myself.
Yes.
What was the outcome, Rekha ma'am, in this
Better
case?
to put laparoscope and give her a final diagnosis with pictures.
Yes, and histro.
Yes, histro. Thank you so much, madam.
Thank you very
and
much.
Panchan sir and Uma madam, Rekha madam. Thank you so much for joining. And we are running little late for the panel. So Dr. Kalpana ma'am is also ready. We shall begin with our panel. Thank you for joining.
Thank you very much, Sejal madam, for a detailed and nice discussion regarding the hysteroscopy. And I also extend my thanks to chairpersons of the session, Dr. Panchan Das sir, Dr. Jyoti ma'am, and Dr. Uma Devi madam. I like to ask Dr. Richa to introduce the next panel discussion.
So now next we move on to the panel discussion. The topic for today's panel discussion is complication of laparoscopic surgery. So I request Dr. Kalpana Chaudhary madam to moderate this session. Madam, she is a senior consultant, gynecologist and obstetrician. She is a present secretary of Guwahati Obstetric Gynecological Society. She has worked at Dr. Norman Tunnel Hospital, Meghalaya for 18 years. She is a recipient of iPledge for 9 Achievers Award 2018 under CMS funding from Union Ministry of Health and Family Welfare. She is also a recipient of awardee of recognition from the Health Department, Government of Meghalaya. She has presented various papers in zonal and national conferences. Her field of interest is obstetrics and endoscopy. Our experts for today's panel is Dr. Praful Doshi sir and Dr. Murgesh Patel sir. Dr. Praful Doshi sir is the director of Me and Mummy Hospital, Surat. He is a consultant at Blossom IVF Center, Surat. He is a professor of gynecology in the medical colleges of Jamnagar and Surat for 18 years. He is examiner for MBBS. Has diploma in advanced endoscopic surgery from Germany. He has advanced IVF training from USA and Australia. He has undergone extensive training in gynecologic oncology at Cancer Hospital, Ahmedabad. The bandwidth of 35 years of his vast experience includes advanced laparoscopic surgery, urogynecology, and IVF. His other interests are music and reading. Dr. Murgesh P. Patel, sir. He has diploma in endoscopy from Germany. He is director at Mother Care Hospital, Mehsana, Gujarat. He is a scientific secretary of Mehsana Obstetric Gynecological Society. He is a joint organizing secretary for SOVOC 2011. He has been invited as operating faculty and has delivered lectures at various national conferences, FOXI, IAG, AAGL, ISG, and PAGS. So I welcome all of you. Now I request Kalpana madam to give a brief description of our panelists.
Dr. Richa, you are sharing the screen, is it? I can't see anything.
Yes, ma'am. I'm sharing, ma'am.
I don't know.
Yeah, but it is not visible. That's okay. You stop sharing. Actually, madam, Bangalore, there is a very heavy rain and there
Yeah, no problem, no problem.
internet is not so good there.
Yeah, I know.
Yeah.
So can I share my screen?
Yes, thank you. Thank you for joining, ma'am.
Yeah, thank you, Dr. Sejal.
I was behind you, ne?
We hope.
Just wait.
Have you given a co-host authority to madam? Please make madam co-host.
That's what I'm unable to share.
Company person, please.
Just
Yeah.
a second. I'll just add.
Yeah.
You let me know when ready.
Yes, ma'am. You are a co-host now. There will be below there will be share button, ma'am.
Yeah. But is my screen visible?
Not yet, madam.
Not yet, no? But then I'm unable to share. Why? Just wait.
Ma'am, you keep open that your PPT in background. So
Yeah, my PPT is open.
okay, yes.
My PPT is open. But why isn't it not sharing?
Ma'am, try to log out and re-log in. Probably that would help.
No, ma'am. Just click on the open PPT once. So that is in active mode, and then you come back to Zoom and
She's not able to share.
My PPT is on. Just wait, huh?
you have got the share button, no, ma'am?
I already got.
Ma'am, you click upon the share screen button, then there will be a window will open that will have your PPT.
Yeah, I am clicking. Just wait, huh? But my window says screen documents and advanced. They are showing three.
So go in screens, ma'am.
Go with screen, madam. Click on screen and then whatever you want, the option will come
The
automatically.
Your
PPT will
desktop
be
will
there.
be visible on screen.
Huh? My desktop is not visible here.
Ma'am, go in screens, press the screens.
Yeah, screens only. My screen is open, but my desktop is not visible here. Oh, can I email my presentation?
Yes, ma'am. Hmm.
To Santwan.
Yes, ma'am. I'll give my
Yeah.
mail ID to our WhatsApp number.
Yeah.
Ma'am, you email that. By meanwhile, we can start discussion. No problem.
Okay. Just one sec.
Ma'am, I've shared my mail ID on our WhatsApp group.
Okay. Santwan Mehta, right? HTA. I'm so sorry for the inconvenience. I don't know where it went wrong, but then I'm unable to share. Now I'm sending the email. Dr. Richa, can you tell me how, how much time we'll get for the panel?
Ma'am, no worries. Just we can start discussion also, ma'am. That is fine. Our purpose is to share knowledge, ma'am. That is fine.
Yeah, but just wait.
You take your time. Ma'am, we can do, you can send the email simultaneously. You can try once more.
Yeah, it's
With
going
the-
on.
yeah.
Yeah. It went. Please check.
Yes, ma'am.
You got, I think, no?
I've just kept it open. Once I receive it, I'll share it with you.
Yeah.
Keep on refreshing it.
Yes, I got it. I'll just open up the presentation. I think I got, ma'am, one
Yeah,
PPT is there.
Could you
Yes,
upload it?
ma'am. Just a moment.
There's one video also. Videos are separately, and
Yes, so I'm going ahead with the presentation first. You let me know when you want to.
yes, sure.
Okay, so my screen is shared right now, right?
Yeah, I can see. But then it, just wait. Can you bring the, can you show the first slide? Like,
That is the, okay,
no, the second slide came overlapping, I think.
just a minute. I'll just,
You need to download it, na?
yes, ma'am.
Without, should I start the discussion without,
Yes, please. Yes.
otherwise, because the time is going.
Yes, ma'am, please.
Right. So good afternoon, everyone. Like, I would like to thank Dr. Sejal and Sunita ma'am, Dr. Subhash, and everyone for giving me this opportunity. I hope my panelists are here today. Dr. Sonia, Dr. Rashmi, Dr. Pranay, Dr. Harish, right? Like, are they present, Dr. Sejal?
I can see Dr. Sonia, Dr. Mrugesh is there. Dr. Harish was also there. Yes, sir is mute and video is off. Please kindly switch on your video, Dr. Mrugesh, Dr. Harish. Dr. Praful Doshi, sir.
I'm talking to Dr. Harish sir and Divyesh sir
Yeah.
both. Give me 1 minute.
Yeah, Dr. Praful Doshi, sir, I am unable to see him.
Dr. Panchanan,
Dr.
Dr.
Mrugesh is here.
Dr. Rashmi.
Dr. Panchanan, sir, can also join. And Dr. Pranay, sir.
Dr.
Pranay, sir.
I didn't see him, I think.
We'll try to call him, sir.
It's okay. Let it be an open discussion. Let everyone join in the panel.
Yeah, great. Yes.
I am Dr. Harish. I am here watching you. I am not able to start my video somewhere for some reason.
Sir, yeah.
Yeah. Please allow Zoom workplace to access you.
So we won't be, because I am having some problem with the with sharing. So without the slides, I think we'll just have a discussion. So we know that laparoscopy has developed into a major tool in gynecological surgery now. And initially, when laparoscopy started, it was just for diagnostic procedure. And now, like almost any surgeries which are performed laparoscopically instead of laparotomy nowadays. So we all know that the learning curve of laparoscopy is very slow. And the complication rates also are more in the initial phase of our experience. So as our experience goes, as our skill becomes better and better, the complication rates are also decreasing. So anyone can help me out and tell me the risk factors of laparoscopic surgeries. Like Dr. Sonia, if you are there, you can just tell about the risk factors of laparoscopic surgeries.
Risk factors in the sense, are you talking about the complications which usually happen, or?
Yeah, the risk factors which we are always to keep in mind, and we are to select the patients in that way. And we are to prepare ourselves before starting a laparoscopy.
Before the surgeries. Okay.
Yeah.
Yes, ma'am. Ma'am, in laparoscopic surgeries, we have to be cautious because in open surgery, it's okay. We are very much versed, but then because it requires a long curve, learning curve as well. So we need to know about the patient's history, examination and everything, what we always do, but whether the patient is obese or not.
Correct.
And that is very important because the angle of the Veress needle will depend on that. So if it is very obese, the angle will change. If it's very thin, the angle will change. And then we have to think about, like, if we are operating on the ovaries, supposingly. So which side we have to operate? Ovarian cyst is on which side we have to get it, because the entire OT setup will be according to that. If you're going to operate left side or whether you're going to operate right side, and the surgeon where the surgeon feels comfortable to stand, because different surgeons have different these things. Then secondly, if what ports are we going to have it? Because if it is like intra-abdominal disease, and which side, so the ports also we need to decide previously only, that what all ports I'll be deciding and what all ports I'll be operating on. Then the extension means if it is like a very complicated kind of surgery, like we are expecting so many additions, like bowel additions, are we really prepared? Because in laparoscopic surgery, the entire field, my whole field of vision is in my assistant's hands. It is not like I am seeing the things directly. And the 3D vision is also, like, in spite of the 3D cameras, but directly eye vision and the vision which we see in laparoscopy is definitely different, because wherever what we know, where there only we'll be putting the camera. So we should have a thorough idea of the disease, like the extent of the disease I was talking about.
Exactly. We should have an idea of the extent of the disease. Like, we should suppose the patient is a post CS case or anything, previous surgery, like the patient is having. So we should anticipate adhesions also.
Yes, ma'am.
So these, we all know, like obesity or previous surgeries, these are the major risk factors actually. For laparoscopic surgery, the incidence, like there are various studies regarding the complications of laparoscopy, but still it is around the various studies reports, like it's around 4 per 1,000 cases, 4 to 4.6 per 1,000 cases, and the complications are more at entry. Like 50% of the complications of laparoscopic surgeries are at entry, and 25% are recognized in the post-operative period. So we have to be very careful at the entry point only. So in general, we all know, like the complications of laparoscopic surgeries are like maybe anesthetic complications, maybe position-related complications, maybe access-related complications. Complication may be due to pneumoperitoneum. Intraoperative complications might be there, and at the same time, the post-operative complications. Now, coming to position-related, I won't go into details. We know only because many a times we are not aware that the position of the patient, which we prepare the patients before the surgery, that itself might have a complication. Like nerve complications might be there. So we have to be very gentle while positioning the patient. We shouldn't be very rough. Then regarding access means entry, what are the prerequisites which are necessary? Like, how do we prepare a patient for laparoscopy? Anyone can take the call. Like, how do we prepare? Am I audible? Hello?
Yes,
Hello?
yes, madam. Very well audible.
Yes, yes. Anyone can take the call and tell, like Dr. Pranay, Dr. Rashmi, Dr. Harish, anyone who is there, like what are the steps for a safe entry actually? Like what do we need to ensure that there is no complication during our entry into the abdomen?
Hello.
Hello?
Unfortunately, I'm not able to start video. I don't know what is the problem.
You can say, no, sir, you can just say. You can just say that.
Yeah. Okay,
How do we prepare, like what do we want in a patient prior to surgery so that we are very sure
See, I
that
tell you, before thinking about how to enter into the abdomen,
yes,
that is a primary part, right?
yes,
So whether the abdomen is virgin or has undergone previous surgeries.
exactly.
Previous surgery is like a simple surgery. Patient has undergone a cesarean section, or say a simple lap surgery like cholecystectomy or appendectomy, or maybe other simple surgery. The entry point, entry will not be that difficult. But the patient who has undergone surgeries, complicated surgery, like previous laparotomy for appendicular abscess or peritonitis or intra-abdominal adhesions, or some patients nowadays we do get in young age, when they have undergone some surgeries for correction of intestinal problem as a congenital problem in childhood. In such situation, entry is going to be difficult. Otherwise, in a straightforward case, you can plan your entry if you are comfortable using Veress needle followed by 10 mm trocar entry or a direct 10 mm trocar entry, or some people, especially the surgeons, they go for an open technique. Every technique has its own merit and disadvantages. Nothing is 100% safe.
How do you prepare the bowel of the patient, sir?
Okay. You are asking about bowel.
Yeah, the preparation I'm asking.
Yeah. Bowel preparation usually I give liquid Movicol.
Okay.
It's 25 ml to be diluted in 100 ml on a previous 2 nights, right?
Yes, sir.
Today. And secondly, I ask them to take liquid diet or say thick liquid diet on a day prior to surgery, and maximum 4 hours of nil by mouth.
Okay.
Nothing. I don't prefer Paglac unless there is a previous history of, say, as I said, surgery, complicated surgeries where the intestinal adhesions are more likely, possibility of damage to the intestine is there, and which may require surgery. Otherwise, no.
Any specific reasons for not using Paglac?
Paglac usually causes dilatation of sigmoid and pelvic column, and it does come in between the surgery while performing the surgeries.
Yes, sir.
I am an oncologist actually. We used to give Paglac very, liberally before. But once we realized that this is the problem which is happening, so we stopped using Paglac unless when we are expecting intestinal maneuvering, intestinal surgeries. There is possibility that we may have to deal with some sort of intestinal complication or intestinal surgery, adhesiolysis or suturing or etc. When there is possibility of tear of intestine or there is leakage of intestinal content, and we have to go for either primary suturing or maybe sometimes resection anastomosis like that. Otherwise, not.
Okay, sir. So good bowel preparation, bladder also has to be catheterized, an experienced team is needed, equipments has to be proper. So, and patient has to be empty stomach. So these are the prerequisites actually. And so now regarding the Veress needle, now I think we all will agree that we all use the Veress needle, and some go for the blunt technique and some go for the open technique too. But while using the Veress needle, like which point would you prefer? Which is the port of entry actually, sir? Ideally,
I'm not. I tell you, I am not using Veress needle at all. I keep my trocar very, pointed trocar. I may have to frequently change my trocar. But the point has to be sharp. Even if I'm going through the umbilicus, if I'm going through the, supraumbilical, I straightway go for a direct trocar entry. Only when I'm thinking to go in a palmar point, at that time I use Veress needle, or even in that also I have changed my technique to go for an open technique.
Okay.
But if someone is preferring to go for use Veress needle, probably the best place to insert Veress needle is subumbilical region through the umbilical.
Yeah. And the alternate sites, like other than the umbilical point?
When we are thinking to go for a lateral entry,
yes,
then maybe a Palmer's point.
Yes, the Palmer's point. I hope everyone knows where is the Palmer's point. It is 3 centimeters below the left subcostal border in the mid-clavicular line. So the Palmer's point also we can. Hello?
Yes, ma'am, go ahead.
Yeah. We can always. Hello.
Hello.
We can always use the Palmer's point as our insertion point. And when there, like usually we use the Palmer's point when there are suspected adhesions or when there is any umbilical hernia, or if 3 failed insufflation attempts at the umbilicus are there. If 3 attempts are failed, then we should ideally go for the Palmer's point. And there is also the Jane's point nowadays. And Gain point can also be used. Now the safety tests, I hope everyone knows what are the safety.
Can I add one point, ma'am?
Yes, sir.
Can I add one point, ma'am?
Yes, sir. You can.
Dr. Mukesh here, ma'am. Yeah, ma'am. Regarding the primary intention, I prefer to use different technique in different placements also. You can use a very needle, you can use a direct current, you can use different patients, particularly in case of the normal patient without any previous surgery. So once you are accustomed with the one particular procedure, like Dr. Array said that they are very comfortable with the direct current. But sometimes, many times you face the problem. At that time, if we are comfortable with using the various needle, then it's very safe to use various needle once we are used to it. So the chances of injury with the various needle is less rather than the direct trocar entry. But I should recommend people that you should be used to with the different techniques, direct trocar entry and various needle also.
Exactly. In fact, sir, to be frank, I myself, I am accustomed with the like direct entry, but with the blunt trocar. So I'm so used to using a blunt trocar, that means I hardly use a Veress needle.
Yeah, it's okay, ma'am, but it's accustomed the different procedure is very good for us.
Exactly. Exactly, sir. And it's the it depends to which system like one is accustomed to, actually. And
Exactly, madam. Exactly. The system with which you are accustomed, you can go ahead. Exactly.
Now, whether
the moment I pierce the peritoneum, I will know, yes, I have pierced the peritoneum. I will draw my trocar. I pass my telescope, and under guidance, I will move forward the cannula.
Exactly. Only thing is that suppose we are using Veress needle, we have to be very sure that we are hearing the double click sound. We do the aspiration, we do the hanging drop saline test, and plus the needle waggling. Like once the needle is inside, like we pierce the peritoneum, we move the needle to see whether everything is free or not. And whether it is Veress needle or it's direct trocar entry. So the complications are almost same at the point of entry. Like complications same, but the intensity is more. Suppose we use a direct trocar, the intensity of complication is more. But what is important is we should recognize the complications early. We should know to recognize the complication early. That is more important, actually. And now, suppose while be it a direct trocar or be it a Veress. Suppose the direct trocar is in the preperitoneal space, or it is in the or the Veress is in the preperitoneal space, and there is extraperitoneal insufflations. How do we know? How do we know that there is like we entered into a wrong space? Anyone can say?
Hello.
Yes. Yes, sir.
Mukesh, are you going or shall I go?
Sir, you continue.
Yeah. Ma'am, I do not start inflation without confirming that I am in peritoneal cavity. I put my scope inside, confirm it, then only I could. And if I recognize that I am not in peritoneal cavity and it is an extraperitoneal space, I just withdraw. I go perpendicular.
Yes, sir.
Because most of the time when we enter into extraperitoneal space, it is because we have gone little tangential.
Yes.
So I again leave the abdomen and go perpendicular. And even if second attempt also I go extraperitoneal, probably then I go for an open tank.
Yes, exactly, sir. That means like we get crepitations and with the pressure is very high, the pressure shoots up actually. So in that case, we know that we are in the extraperitoneal space. Now, thing is that when we are using Veress needle, we have to insufflate before putting the scope. So the chances, like suppose we are confirmed that we are in the extraperitoneal space, then we need to withdraw the needle or the trocar, and we need to let the gas go out, let the gas escape, and then we need to reintroduce through the same side, but with perpendicular direction. Now, suppose there is a situation like we call it pneumo-omentum. Now, pneumo-omentum means the omentum is, there is adhesion, and we introduce the scope and we see that we cannot see the peritoneal cavity properly. We can see only the omentum there. And in that case, there is a chance of omental vessel also to be punctured. Yes. So in what to be done? Suppose we realize that we are in that omentum and we can't see anything. What is our
madam, in that situation, because we are doing a pelviscopic surgery, right? So we usually immediately go down.
Yes.
Our telescope and camera is tilted downwards. But we are looking into the pelvis. Instead, we just turn our camera and telescope and see the upper abdomen. There is always a space. There is always a space on the lateral side. You move your telescope and camera on the left lateral, and then you move. And probably you will definitely get some place to enter a second trocar. And by that you can manage.
Would you like to see it like from another secondary port, like a 5 mm scope?
Yeah, that also can be done. That also can be done because now we have inflated the abdomen. There is no difficulty in inserting the second trocar. But usually it is always possible. If you move your telescope on the left part of the abdomen and move little more towards the splenic side, then probably that is always a virgin area, as it is being discussed for the safety as regarding the Palmer's point. The same applies over here also.
Yes, sir.
Then you insert a second trocar, use 5 mm telescope and camera, and then visualize the primary entry. And then if there is any difficulty, you sort out that.
Acha. Thank you so much, sir. Now, have you heard, have anyone come across any pneumothorax cases during entry? Usually it is more common with the surgeons, not with the gynecologists. And suppose a patient develops pneumothorax after putting the Veress needle or after putting a trocar, primary trocar. How do we manage that case? Would you like to go ahead with?
I have never come across anytime.
Yes, sir.
Even, you said it is common with surgeons, so why? I would like to know why.
Yeah, we are not supposed to discuss.
Same as we are. Primary entry point is the same as we are going. I don't know why. Unless they are operating somewhere like diaphragmatic hernia or Nissan's spondyloplication, during the surgery, it can happen. Otherwise, not.
Yeah, but as soon as suppose anyone you realize that a patient is having pneumothorax, then the surgery should be abandoned. Laparoscopy should be abandoned.
Obviously, and there has to be. It has to be drained.
It has to be drained. We have to test.
Thoracic.
Yeah. Now.
Patient record very fast.
Sir.
Once it drained, the patient recover very fast.
The patient will recover very fast. True, sir. Now, coming.
Immediately you can know because SpO2 will start falling because the lung cannot inflate.
Yes, sir.
In spite of high pressure oxygen.
Yes, sir. And now coming to, suppose we are giving the secondary port. While giving the secondary port, we realize the patient is bleeding. We put the scope in, and from the port side, there is blood is trickling, and there is active bleeding. in that case, how do we control that bleeding from a second report? We have the scope inside the abdomen, and we see that from the secondary port side, there is active trickling of blood. How do we deal with it?
Oh, ma'am, we can have one more port, and through that port, we can see from where because we have the scope inside, so we can have one more port inside, and then through that, we can put the instrument and coagulate it after withdrawing the port from that side. That also can be done. Or
and still it's bleeding, it's not stopping.
Ma'am, from the third port I'm trying, no? We have to take out the second port, and then from the third port I'm introducing my bipolar or whatever I'm using for cauterization. Then I can go to that point, I can cauterize it, and then again I can put the port from the second port again.
Yes, no, suppose you are trying to coagulate and it's not being cauterized, and you see
And then with the port closure needle, we can close it as well. We have the port closure needle, no? So that also we can have a stitch from there.
Exactly. It's always better, like if we see that it's oozing, it's trickling from that point, if we see a bleeder, then it's always better to put a needle passer and then put a bite, like 2 stitches around the...
Then how will you proceed for surgery?
No, the trocar will be inside, sir. The trocar will be inside. You just put a needle passer and then take 2 bites, like one on top and one behind.
Okay, I have not faced this situation even after doing more than 10,000 surgery. I have never faced this situation. But the better will be you put a Foley's catheter. Just
that is also true. With
and pull it. And most of the time, this bleeding, we see bleeding and immediately we are worried. But most of the time, this bleeding is from the subcutaneous space or like that. It is never subperitoneal vessels or unless there is adhesions. Omental adhesion is there and there is neovascularization. Otherwise, primary entry point bleeding. Sometimes even after completing the surgery, if you don't see while withdrawing, probably there can be some bleeding and which may be left. And very rarely I have heard such situation that they have to go for resurgery for hemoperitoneum. But otherwise,
yeah, that's true, sir. But then sometimes it can really be troublesome. And I have vessels, and then first of all, we can give pressure with the trocar itself. With the trocar itself. Pressure, and we can use the catheter also. Then we can use the cautery also. And if still we see that blood is trickling, then we can go for the bite. And suppose we see a retroperitoneal hematoma. Like, what is the line of management in that case? How do we deal with a retroperitoneal hematoma, which we realize like while the procedure is being undergoing?
Dr. Sonia is here, ma'am. I think.
Yeah, Dr. Sonia, you can say.
Ma'am, retroperitoneal hematoma, if we are thinking of, then first I have to see whether it is increasing or decreasing, because retroperitoneal can be what kind of vessel I have to identify. Like if it is external iliac or some internal iliac or whatever, or it's a small twig, because it depends on the size of the hematoma. And definitely, if this is the thing, then we have to explore it, but not at the same time. If it is too much, then definitely we have to abandon the surgery and open it and call a vascular surgeon and take a call like that. Or if we are compatible enough, then we can go ahead with the laparoscopic approach only. But it depends on the skills of the surgeon. And I think oncologist sir is a better person to handle this question and add something to it.
No, what I understand, what is your question is, you are asking about the retroperitoneal or extraperitoneal hematoma at the primary entry point. You are asking the hematoma while performing surgeries like radical hysterectomy or simple hysterectomy and
any time, like during the entry point, like after entry also, or suppose intraop you're doing and you
most of the time, madam, such situation we don't go for irrigation. We put a gauze piece inside, try to pressurize with the gauze piece and Maryland forceps, and by that observe for few more minutes, deflate the abdomen and see again whether it is increasing or not. If it is not increasing, probably it is a venous hematoma and you don't need to do anything.
Not
right?
anything.
If it
Exactly.
increases, it means there is an arterial hemorrhage or there is a big vessel tear. Obviously, if you are competent, you can open it, or even laparoscopically also you can open that particular space, identify the bleeder and cauterize it, or even you can take suture. But they are very, very difficult situation. One has to be very cool while going for this surgery, because here in laparoscopic surgery, the whole people, all people seeing in the, sitting or standing in the OT is ready to advise you, do this, do this, do this. But you are, right?
And that makes you panic more. Yeah.
You have to, that surgeon has to take call out of his experience.
Exactly. So means retroperitoneal hematoma doesn't mean that we need to call a vascular surgeon. But then we need to see whether it is increasing or whether it is same. And if it is same, nothing to be done. And if it is increasing, then we definitely need to think of a big vessel. We need to try the compression part first. And then if needed, we need to call a vascular surgeon. Now, coming to suppose while during the entry with a varus or a trocar, we see that there is a laceration in the in the small intestine. There is a laceration in the small intestine. Means the varus needle is inside the small intestine, suppose. Now, how do we deal with that? What next?
But how can we know that varus needle is in small intestine? Because unless when we remove the needle, we pass the trocar and cannula and scope, then only we find out.
On aspiration, we see that dirty fluid, and foul-smelling gas comes out and dirty fluid comes out from the varus.
Then it will be in a large bowel, madam. If foul-smelling gas comes out, then it is a large bowel. Small bowel.
And suppose aspiration.
No, I answer your question, ma'am. If it is in small bowel, right? Whatever is the way of entry, then what, as a gynecologist, you have to do is you identify that point, then make some identification mark on the mesentery. Because small bowels, they start moving once you deflate the abdomen or otherwise also. So either you put a stitch over the mesentery or put some bipolar, go for bipolar superficial fulguration. So that later on, whenever you call a surgeon, he or she will be able to identify that particular point. Otherwise, it is difficult to relocate that particular point. And if you are confident, you can suture with 3-0 Vicryl. No problem.
Yes. Sir, is it mandatory that the surgeon has to be there? Suppose it's
no, not necessary. Basically, we all are surgeons.
Yes, sir. From medical legal point of view?
Medical legal point of view, if you are okay that yes, you have done your job very well, then probably it doesn't matter. But if in a post-operative period, say 3rd or 4th day, patient comes with leak and interperitoneal peritonitis, probably you can be asked.
Exactly,
that
sir.
Yes, you have managed such situation in past also.
Yes, sir.
Otherwise,
better to keep a surgeon aside away.
Yes, sir. So
I am being associated with GI surgeons also. We had a team, and even in GI surgeons hand also such thing happens, that they always prepare the patient. Once they have such situation, they prepare the patient that I have taken it very efficiently and very meticulously sutures, but probably after starting the soft diet, there is 10% possibility or 5% possibility of leakage, and we may have to re-explore. So that situation even happen in the hands of surgeons, GI surgeons also. There is nobody's, GI tract and urinary tract is no proof.
Exactly, sir. So be it like GI tract or be it urinary tract, like even if we know how to repair, it's okay. We can repair, like single layer repair will do. And we used to repair, but it's always better to keep a surgeon or a urologist by the side, so that just to save ourselves from litigations only. But then you have mentioned a very important point, sir, that in case of GI injuries, small bowel injuries, or be it large bowel, like if we should mark it. We should mark it by cottering the mesentery so that it's easy for us to locate the site. That is very important, and we should keep in mind that part. And
Ma'am, I would like to add something over here. I had a lecture on this thing, entry techniques in laparoscopy, and then I happened to study Greentop guidelines and Cochrane guidelines and all those things. And what they had told is that it doesn't make any difference with whatever entry procedure or entry method we are using, whether it be varus needle or whether it be trocar. But they had only one thing, that the entry related complications are less when we introduce the trocar, direct trocar entry, as compared, the direct trocar entry is related with lesser complications while entry as compared to varus needle. And the waggling of the varus needle is also omitted nowadays. Now we are not waggling to see whether we are inside this thing or not, because many a times it gets into the bowel or in the vessel, and then waggling increases the hole or whatever point of entry it's there. So they are omitting this waggling thing in these tests, whatever we have mentioned up till now.
Okay. That's true. In fact, with direct entry, like the complication rate is less. And
only
now,
thing, you have to keep your trocar very sharp pointed.
Yes.
You may have to frequently change your trocar, because your staff may not be that competent or may not be that careful to, when they are washing, sometimes it drops and the point get blunt. And with that blood point, it is very difficult to be in exact position. Pierce the peritoneum and seat, especially seat.
Yes.
Sir, I'm sorry, but I have always used blunt trocar, 10 mm trocar, and we never faced any problem in entry. Always a blunt.
But then how you are piercing the rectus seat?
So everything gets pierced very nicely, sir. We in our setup actually.
Okay, I will try next time. No problem.
No, can I make a point, sir? You can use a artery forceps to for the blunt. Sometimes I do use to separate the interfacial this thing. But blunts, I think I agree with sir. Sometimes it doesn't go. It's difficult also, especially when the thick fascia is there.
Because the surgeons who are using a direct, open technique, they usually cut the seat with 11 number knife, and then they have some surgeons have devised the instrument which has a blunt end on both the sides. What we use for making rotis and etc. What we call a velan in Gujarati, and then they pass that velan inside, and over it they slides the primary cannula, 10 mm cannula, and then they go inside.
So that is why I use the artery forceps, straight artery forceps, to make it little site more permissible.
And the difference will be if you have used direct trocar, pointed trocar, you can avoid suturing it. But if you have used open technique and cut the seat, it is mandatory to suture the seat. Otherwise, there is high probability of incisional hernia developing in that port site hernia.
Yeah. Yes, sir. 10 mm always we suture it. The sheath we always suture in 10 mm.
It's always better, like ports more than 10 mm should be sutured only. And
sharp trocar with the rotating movement is a very safe procedure. Sharp 10 mm trocar with the rotating.
Sir, without the varus needle.
Yeah, without the varus needle. Direct trocar entry, madam.
Since we are not...
Actually, I tell you how we are accustomed to this, because I have been in a government setup for nearly 10 years of my early practice, when we used to go for laparoscopic family planning operation camps.
Okay.
Right? We do on an average 20, 25 on an average, but in one day even we have performed more than 100 also.
Okay.
Right? So in such situations,
those are postpartum, or you are saying, or like...
No, it's a interval TL, interval lap TL. And then we are used to that confidence. Initially, there is fear, but once you perform more than 100, 150 or 200, you get accustomed. That click of piercing the rectal sheath and peritoneum, the way we have double click recognition in Veris needle, the same thing happens here. And fortunately, I don't know, I touch wood, I don't face the problem in future also.
Sir,
But
have
it's
you,
efficiently very safe.
in case of,
I make this point very much. I'm agreeing with sir that PPOT postings have helped us that direct TOCAR confidence. That is very true.
that is true. And in case of post CS cases also, or post patients with history of past surgeries also, sir, you are using that direct.
Yeah, madam. Previous 3 scissor, no problem. Previous laparotomy, no problem.
Okay.
Only when there is a laparotomy and there is a ragged scar on the abdomen, means the external area is not good, means internal area, peritoneal surface is also not going to be good, and there are possibility of intestinal adhesion. In that situation, we have to be very careful.
Acha. Now, apart from the entry, like be it trocar, be it Veris needle, we encounter complications while doing dissection. Now, suppose an endometriosis case with deep infiltrating endometriosis. What are the precautions we are supposed to take during the dissection so as to avoid both bladder as well as bowel injuries? Anyone can say, sir.
Brugesh?
Hello?
Brugesh Patel?
Yes, ma'am. Yes, sir.
Yeah.
Can you, sir, please tell us?
Deep infiltrating endometriosis, you are going for the surgery. Where
Yes, sir.
you will take?
What are the precautions we'll take so as to avoid bowel injury and bladder injury or ureteric injury?
First of all, we have to recognize the virgin area. Start your surgery from the virgin area, and there should be a space. So go ahead with any instrument or any surgical energy sources you are used to it. I am used to it harmonic also, and I'm used to it bipolar dissector also. But when there is a dense boiling adhesion, then you should shift from a energy sources to the cold scissor. That is very safe. If you even injure the bowel, then there is a lesser chances of a slough out of the suture line.
Exactly, sir. I agree to you 100%.
Ma'am, exactly. See, whenever there is such complicated cases, the best thing is to start at the pelvic bridge.
Yeah, and
you identify that lateral space between round ligament, ovarian ligament, and come on the one side and sigmoid colon on the other side. Dissect out the sigmoid colon, enter into the lateral wave. Again, if you are handling on the right side, enter into the lateral wave. Identify the ureter, if from lateral side, or else sometimes if it is possible from the medial side also, at the pelvic bridge, crossing over the common iliac vessel. Take out the ureter, dissect out ureter till it goes into the tunnel. That means till the uterine artery, going under the uterine artery. At that time, if you are managing endometrioma, probably you have to be careful, because once you go for separation of endometrioma from ovarian fossa, it is usually going to eventually rupture. You have to give a proper irrigation. Some assistant has to hold it on the upside down, and then you proceed and dissect the ureter. Then, if it is left side, again, it will be little more difficult to go from the medial and medially. You have to go on the lateral side only, because on left side you have there is sigmoid colon mesentery comes in the way. If you are lucky, probably you will be able to dissect from the medial side. Once that is done, you have to leave the uterus, that rectovaginal space, right?
Yes, sir.
And I have my own technique. I have seen so many surgeons now doing without doing much manipulation from the below. They usually dissect from the above, from the pelvic brim. They go on the lateral space lateral to the uterosacral, medial to the uterosacral. They call lateral pararectal space, medial rectal pararectal space, and then they go in pouch of Douglas. Instead, what I do, I have a manipulator inside. I ask my assistant to put 2 fingers in the posterior fornix and lift the uterus, just like we are correcting retroverted uterus to the anteverted uterus. The moment he does it, he or she does it, that endometriotic infiltration will tear off, and immediately you will be able to recognize the uterosacral inserting into the posterior wall of the cervix, and that will facilitate further dissection. And obviously, if we put a small gauze piece rolled over the swab holder, probably, and asking the assistant to keep 1 finger in the rectum, you will exactly know the margin in rectovaginal space. We are oncosurgeon, we know how to do Vardhaim, so there is no question. We can dissect rectovaginal space till the level of almost upper 1/3 of the vagina or beyond that. But in endometriosis is a different thing. That is a clean surgery. This is not a clean surgery.
Exactly, sir.
If there is infiltration into the rectovaginal space, that case for malignancy is inoperable, especially cervical cancer I'm not talking about. But endometriosis, we have to operate, right?
Yes, sir.
So the important thing is you have to isolate the ureter, you isolate the rectum and rectosigmoid, and then proceed further for the surgery.
Exactly. Very well said, sir. Like
The thing is that if you believe that whatever tissue I'm taking is not a part of rectum or rectal wall, that is a wrong concept.
Sir, pardon, sir?
Means sometimes we feel that whatever tissue you are dissecting, rectum is not there, rectal wall is not there.
Yeah.
That is a wrong concept. Instead, you properly locate what are the limits of rectum, lateral rectal wall on both the sides, left and as well as right side, and the proper rectovaginal space dissection. And then you remove that uterosacral or rectovaginal nodules.
Yes, sir. Like the take-home message is like we should use, first of all, like in case of deep infiltrating endometriosis, if we are close to rectum or to the bladder, we better use cold scissors rather than using electrosurgical instruments. And plus, I've personally, from my experience, I always try to dissect from the normal side towards the abnormal side. So I feel that makes dissection easy. And now coming to electrosurgical complications, we need not discuss in detail. What we should remember always is we should keep the tips of the instruments in the center of the screen always while in
case of endometriotic surgery, patience and experience are more 2 key points. You should be very patient. And when you feel that there is a bowel involvement, then you should go fiber by fiber. Then there is a very less chances of injury.
Less chances of injury. And sir, they say that if we are removing any endometriotic spots from near the ureter, like it's better to instill some saline before using any cautery very near to the ureter. So I don't have experience regarding that. But
No, ma'am. I'm not using the saline at the ureteric lesion because it's better to go directly, because sometimes if you are not used to with this saline insertion, then you might lose the real plane and you might injure the tissue. I'm not used to it.
But some surgeons, they prefer like instilling.
Yes.
And regarding electrosurgical complications, like we should remember that we don't use 2 different energy sources in the abdomen at the same time.
Yeah,
And
exactly.
that is not advisable. And post-operatively, patients, they become better and better as the time goes. But if the patient keeps on complaining pain, or in case of the very deep dissection patients, and if the patient is having fever, pain, abdomen, then we should keep bowel injury or ureteric injuries in mind, and we should evaluate the patient accordingly. So we should not be too relaxant also. We should keep the complications in mind, even how much experienced surgeon we are. We shouldn't take things lightly also in today's era of litigations, and our
The first and foremost, first investigation in such situation is CT scan with contrast.
Yes, sir.
That has to be done, and once that is okay, then you can keep the patient on a conservative side. Otherwise, that is the first and foremost, whether it is ureteric or whether it is bowel related problem.
Yes, sir. Then
it should not be deferred.
Exactly, sir. So hello.
Hello.
Like it requires 4 to 7 years to gain adequate laparoscopic skills by doing several procedures each week with gradually increasing levels of complexity. We should do more and more cases. And like complications doesn't mean that we are a bad surgeon or our skill is less, but it means that the surgeon who is not having any complication means that he's not doing any case. So we should keep on doing cases, and we know complications will be there, but we should know how to deal with the complications. We should be very careful, and we should know how to deal with the complications. We should know how to select the patient, like appropriate patients for laparoscopy. We should know. We should do the bowel preparations properly, and patient selection should be good. Patient counseling should be good. We should discuss with the patients in simple language and document all the risks and benefits and the alternatives to laparoscopy too. And we should consider conversion to laparotomy if difficulties are encountered. We should not think that if we have to convert to laparotomy, that is a failure on our part. That shouldn't be the thought. So if at all we feel that we are not experienced enough, or we feel that it is not, it's beyond our expertise, then we should always go for conversion. So we should consult an appropriate colleague if a complication occurs also. And this colleague can be another gynecologist or a general surgeon or a vascular surgeon, whoever. So we had a very nice discussion. Thank you so much, sir. And ma'am, everyone has got their inputs. I think we are quite late today. That's why I feel better we conclude here. And the take-home message is adequate training reduces laparoscopy-related complications. Troubleshooting guidelines are mandatory, and conversion to open should not be seen as a failure. So thank you so much.
Can I add one point, ma'am?
Yes, sir.
Always mention your complication in paper, and always inform the patients relative regarding the complications. It's better. The complication has to be happen to be there. So always mention and always discuss in detail with the patients also. It's better to be transparent in such cases.
Yes, sir. Very true.
Just one point, Kalpana, when Mukesh bhai, Harish sir, Badda che, Sejal che, how many of you are using the Illuminant ureteric stent in complicated cases, as madam was talking about the endometriosis?
I use.
But no, ma'am, I'm not using it because I'm comfortable without using it. But some points, some of the surgeons said that if we are used that stent, then the urine become more stout. Become more stout, then it's more vulnerable for an injury rather than a mobile ureter.
No, I'm talking about post-surgery. I've not used pre-surgery after finishing the surgery, and just to see whether the injury has occurred or not. And in great, Harish sir is here. Sir, what is your experience in putting the stent for 6 weeks in a complicated surgery, or maybe 15 days?
I have never required to put a stent
cases of
date.
endometriosis,
But obviously, whenever you have any doubts regarding ureteric injury, it's better to call urologist and put a stent. Once urologist come, they are very liberal in putting stent, I tell you.
I do,
When
sir.
urologists, they are very liberal in putting stent. I mean, obviously, when they have been asked to cover you, obviously they will not leave. It's okay, we don't put. They will
So
definitely.
I'll just reframe my question. If I have operated a bad case of grade 3, grade 4 endometriosis and the surgery is complete, still in lieu of like post-healing, sometimes there's a kinking of ureter and all. I have seen one or two complications in my patient only. So sometimes I prefer to keep a stent in the post-operative healing phase. I mean, Kalpana, Ben, if you have any.
Yes, Dr. Sejal, I myself also, I do the
Dr.
same.
Archana, madam. This is Dr. Archana. Archana Dwivedi. Sejal is here. Next to me.
Yes, ma'am.
Yes, ma'am, go ahead.
Yeah. No, I do use like in case of difficult adhesions or endometriotic surgeries where the ureter is very close to my dissection area. But once or twice I have seen that the patients whom I put stent, they have hematuria. Have you encountered that, Dr. Sejal?
Hematuria and phantom pain has been very common, but I have been relieved, Murugesh bhai, in my practical purposes, though Harish sir has got a vast experience. I cannot compare to, I mean, he's a mentor to me.
No.
But the thing is that sometimes
At certain level, everybody is almost equal.
so this is just my personal experience because we are talking about the complications where the aggressive surgery, as madam has said, frozen pelvis, and where we had to dissect a little larger area and very proximity to the ureter. So I have kept the stents for say 4 weeks, 15 days, and happy with the results. Cautionary.
In such cases, I'm like to leave some tissues, healthy tissues like a fat, and I always try to keep the vascularity of the ureter intact. So even in that cases, we recognize that there is a very lesser chances of injury in such cases if the vascularity is maintained. And only I am in a doubt that I already injured or punctured the ureter or any ball, then and then I need to ureteric stenting after surgery. But I don't think so in a routine cases of complicated surgery.
Not routinely, sir. Not
routine.
The answer is same. She was also in doubt. You also put in doubt when you are in doubt.
Yes.
Right? Yeah.
So
whenever there is doubt, there is no harm. There is no harm.
There's no harm there. Thank you, sir. I think Kalpana ma'am, you did.
Wonderful discussion is going on, and we just don't want to it. But if we look at the time, it is 7 p.m.
You are 7 o'clock now. Few patients are waiting.
Poor endoscopic lover would never want to stop it. I know, ma'am. So wonderful panel, ma'am. Seriously.
Get to know from so many, those who are doing such surgery frequently, we come to know so many things which we may not have experienced such things.
True. As you rightly said, sir, each one dealing with their problems differently, and sharing with their experience in such a platform is really enhancing the skill across the all individuals, sir. And we also have recording of this today's program, so we will soon share this also for the benefit of those who couldn't attend today's event.
That's what. It's
so
nice.
Okay, ma'am. Now, thank you, Dr. Sejal, Dr. Archana, and Dr. Reshmi is not there, but from Baroda Obstetric and Gynec Society, Dr. Kalpana Ben. Very good late evening. Hope
Thank you so
Dr.
much, sir.
Sejal and Dr. Archana, we wish you best of luck for the election.
Thank you, sir. Thank you so much. Endoscopy, I mean, that is a love of endoscopy, all of us here, and I'll be for the midlife committee chairperson. So kindly endorse your blessings to us. And Kalpana, I would like to congratulate you. You took up very apt panel. I mean, that was very nice taking care of all the complications.
I enjoyed hearing, and I had to put my feet inside because Sejal can't control types. Thank you so much, ma'am. Thank you.
That is all. Yeah, always welcome. As Madam already said in beginning that let it be very open panel, and you covered everything, Madam, everything from the entry and
Yeah,
it.
but I couldn't share my presentation and the videos. I brought few videos
That
also.
is okay,
I don't
Madam.
know what went wrong.
Yeah, but the discussion was very, interactive and very interesting. So
Yeah, but
thank you so
yeah.
much from Guwahati to Surat. We are in Gujarat and from South Bangalore to the many years. So we have all collected we are all connected across the country. So this is a great, advantage of the online platform.
Yeah, thank you so
Also
much, Dr.
thank
Sejal and
the
Dr. Archana, especially our
company to
best
support
wishes.
this.
Thank
Yes.
you. Thank you, ma'am. Thank you so much.
Best wishes are with you.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank you so much. So
Okay.
here, I thank everyone. My coordinator, Dr. Richa Pal, she's from Bangalore and very budding and aspiring gynecologist. And she is a friend in one click like that. Love at first sight. We just met for once and we become thick friend. And dear friend Santwan, he's from Bangalore. And we are connected with Dr. Paul's fellow alumni group. And
I am Ahmedabad,
yes,
Bangalore.
oh, sorry, yeah, from Ahmedabad. And we have, after that, we have met for many times. So much academic and very, very thorough, genuine, hardcore endoscopies. So,
So, Sejal,
thank
let
you
us
for the
invite Kalpana ma'am for our Foxy conference. We are hosting, madam, in month of September. All of you, please join us. I'm the organizing chair. That is the month of September 21, 22, 22 we have the conference, and 20 we have a workshop. Do pin me or Sejal, my number is there. I'll just share the brochure in the group.
Yeah,
So
please.
would love to have and see the videos in person.
Okay.
Thank you. So I request all the society, Bangalore, Baroda, Guwahati, Dibrugarh, Navi Mumbai, Shimoga, and Surat Society to kindly please vote and support us. Voting will start from 16th of August, and we shall continue such academic activity even post-election. Thank you. Thank you, Mukesh Bhai. Thank you, sir, for joining this, and thank you, madam.
Thank you so much and best wishes.
Yeah.
Thank you, ma'am. Thank you.
Thank you. Thank you so much. Thank you, everyone. Thank you, Kalpana ma'am.
Thank you. Yeah.
Ma'am, thank you for the opportunity and all the best, ma'am. Sejal ma'am and Archana
Thank you,
ma'am.
madam. Thank you so much, Martha.
Ma'am, thank you, thank you. So best wishes ahead. Enjoy your evening. Had a good academic piece. Thank you, Sejal, for having us all here. And see you soon, all of you. Thank you. Bye bye.